We'll wait for people to start rolling in. So here, it's nice and beautiful in Toronto. Rick always teases me about moving to Florida. So it's one of those days where I can actually stay in Canada and not get teased about it. So I don't know what the weather is like there for you guys, but at least here it's beautiful. People finally starting to go out and enjoy things. So St. John, yeah. So we're live, everybody. So welcome to our Peri-Implant Complications Symposium. And I wanted to introduce our first speaker, who's a dear friend of mine, Dr. Richard Miron. So I've known Rick for, wow, I would say 2003, 2004. We met in undergraduate medical biophysics, which was a smaller program of about 15 people. And we got to know each other really well. And he went on to do his dental degree at Laval. And I went to University of Western Ontario to do my dental degree. He continued on to do his PhD in Bern, Switzerland. And you may be familiar with some of his work related to PRF, and most recently, the Next Generation Biomaterials textbook, which is a #1 seller by Quintessence. So it's my pleasure to have Rick here again to discuss this very important topic, which I think gets neglected because, you know, we see people posting and sharing cases all the time, and we don't see enough complications discussed, whether it's from a biological or surgical and prosthetic standpoint. We do have these deficits that we are not discussing openly. So Rick, it's my pleasure to have you here to discuss this important topic.
Perfect. Thank you for the kind introduction, of course. Always a pleasure to be here, especially on the network. I'm going to go ahead and share my screen right now and we'll get started. So I'm just going to share my screen. All right. You guys can see that? Perfect. So this is actually a topic that I much enjoy discussing. And the reason why, and as you mentioned, the Next Gen Biomaterial textbook, in the textbook, the first chapter, we talked about how important the immune system is. And it was something that we've learned a lot, and I have to give a lot of credit to Dr. Dieter Bossart, who was somebody that I worked very closely with in Bern, Switzerland. But the reality was every single biomaterial that we tested before bone formation or periodontal regeneration was going to occur, which was the topic of the whole book, there was always an immune response. And that immune response actually dictated what would occur thereafter. And so years had gone on after we started doing this research. And of course, when it came to peri-implantitis, it was also a very important factor to discuss immune cells. And I'll talk about some of the work by Tomas Albrektsson and what he's done to discuss immune cells. So of course, a lot of this stuff comes from the time that I spent in Bern, Switzerland, and I have a very close collaboration. I lived there from 2009 to 2016. Always like to give these gentlemen credit. Most of the time, like I said, I discuss a lot of the clinical stuff that we're doing with Tony Schoolian and Danny Boozer, but this is really a biological one. And since I was given the task to discuss biologically what occurs with peri-implantitis, this is where Dieter Bossart as well as Reinhard Gruber really came into the picture. And I'll speak more specifically about this work. So to give an outline, there's 5 key studies that I really wanted to discuss. It's a short topic, but there were 5 things that I looked at and I said, you know what, this is important. And it actually correlates very well with the other speakers. So we're going to start with marginal bone loss around implants. And those are all the studies that were performed in Sweden by Albrektsson. And I want to talk about titanium particle release, which is great because George, the second presenter, will discuss this in much greater detail. The work that we've done in Bern on Osteomax will be the third thing that I'll present, as well as how osteoinduction of biomaterials occurs. And then I'll finish up with the articles that we did while I was in Michigan on basis of bone metabolism around these implants. I think if we're going to discuss this topic, this gentleman right here, Tomas Albrektsson, probably deserves the most credit for all the work that he's done. And some of the things that Tomas has really shown was that he always discussed peri-implantitis completely differently than periodontal disease. So he always was one of these guys very early in his career, and this is dating back 10 years ago. And of course, this is the group that literally developed implants with Brainmark and all their group with Weinberg and Albrektsson. And you'll see, even dating back to 2012, and I remember being with Mark Bishara, we've seen him lecture in Orlando around the same time discussing these concepts. And he always said no evidence was found for primary infection causing marginal bone loss. So he was one of these guys that very early, he said that when you see those little marginal bone loss, it wasn't necessarily caused by bacteria as you see around teeth. He had a combination of factors. So he called them, combined factors, implant hardware, clinical handling, patient characteristics, and really described it as being more related to those. And then he always said it was secondary is the infection. Okay, so it's quite interesting to see. And I think probably Tomas will speak more specifically on all of these different implant hardware, et cetera, complications that can occur. So here, the first thing that he said, and this was dating 10 years ago, he said, if it's really an infection that's going on, why is it that when you have excess cement, that's when you start to see greater marginal bone loss? And when you remove the cement, all of a sudden you get tissue regeneration. So again, this is dating back more than, probably 10 years ago, he was doing this work. And, it's a very important finding. And of course, now today, Tomas will speak about this, I'm sure of it. But you look at these cases here with these implants, this marginal bone loss, unlike around teeth, was not caused by periodontal infection. This was caused by excess cement, right? So this is the first, real indication that, and the reason why I'm showing this is to discuss how important immune cell health is later on, okay? So then his papers came about 2-3 years later. Is marginal bone loss around oral implants the result of provoked foreign body reaction? And that's where a lot of people know Professor Albrektsson based on this foreign body reaction. And he has these models about how on an implant surface, you always have to be in balance between, your foreign body reaction and kind of happiness in your immune cells. So these papers here are very interesting. Like I said, for those that would like to read them, there's a series of them. And he even defined peri-implantitis as being more of a man-made disease. And I think when we hear some of the other lecturers present on this topic, they're really going to go into more detail of all the little things that you can do in order to prevent peri-implantitis here. And again, for him, he was kind of critiqued a little bit in the early going because a lot of people were saying, hey, look, in periodontal disease, you got 2-3 millimeter pockets of stable. Here you have 3 millimeter pockets around these implants. But a lot of it was related to, again, immune osteolysis reactions. And so he was the first guy to really bring this at the forefront of research. And he was many years ago describing all of these different things that were unrelated to bacteria. And he was saying, look, this is all related to immune cells, all these things such as forceps, excess cement, titanium leakage, broken components. All of these things here are bigger contributors to peri-implantitis than actual microbes, okay, and bacteria. And the one thing that was very interesting, and probably a lot of people have not read this paper, to really hammer home on his point, in 2019, he said, you know what, I'm going to go to the orthopedic field. And he was discussing bone loss around orthopedic implants. And the same thing occurs here. And the interesting thing is that these orthopedic implants never come in contact with bacteria in the oral cavity, right? So it's not transmucosal, it's literally implanted in the body and it's integrating into bone. And he was showing the exact same thing occurs around these orthopedic implants. Okay, so in this study, he's comparing oral implants to the orthopedic implants. And when bone loss occurs, and when you speak to orthopedic surgeons and you read their papers, all of their implants, they always recognize them as being foreign body reactions and how important the immune system is here. And the implants here, he even shows these cases with one of his collaborators. Bone resorption occurs around a hip here. The pattern of the bone loss is similar to what happens around oral implants. Bone resorption starts proximally and it continues, eats itself gradually towards the apical region. It's the exact same thing that happens in these dental implants, but here there's no bacteria. So if in your head you have this concept that, you have bacteria, you now have marginal bone loss, and then the bacteria is going around the entire implant, the dental implant, and then you have implant loss. The exact same phenomenon occurs in orthopedics, although in this case here, there's no bacteria. And that's one of the hints that really illustrates that it's actually immune cells that are very, very important here in this concept. Now, this one here, I think, is a very exciting field, and one in which I'm very thrilled. Yesterday, I received a message from George just mentioning that he'd be speaking directly on this topic, and I think it's a very important one. And this one here, I present this one because it's one of my close friends. It was somebody that I work with, Toby Fretzworth, published this article as medical particle release associated with peri-implant bone destruction, an emerging concept. And like I said, the authors here, Kathia Nelson, Dennis Tarnow, Homley Wang, William Ginobili, these are all the giants, let's say, in the field. And again, why was this so important? It was published in the Journal of Dental Research. Well, they showed that medical particle release as a potential factor here is being intensively studied in the field of orthopedics and is known to provoke aseptic noosing around these implants. In dental medicine, emerging information about metal titanium particle release suggests that the potential impact of biomaterials at the abutment bone interface may have an influence on pathogenesis of peri-implant bone loss. So in this study, the one thing that's very interesting about it is, of course, titanium breaks down over time. And that's why you see in the orthopedic field that they actually lose their implants as well. Because when you have these titanium particles that are released, of course, then what happens is it causes immune responses. The immune system is more inflammatory now. And then thereafter, you lose these implants. And it's a very interesting concept. And I think that's one of the reasons why when you see more and more researchers speak on zirconia implants that don't have this titanium particle release, that's one of the reasons why you see more and more of these studies where the long-term zirconia studies, for instance, don't have as much peri-implantitis. And this may be one of the reasons why with respect to titanium particle release. And like I said, the second speaker will speak to this in great detail. Oh, I don't know what happened there. Sorry, guys. I don't know what just happened. I'll get this fired back up. All right. Okay. Okay, so biomaterials in the body is, of course, extremely important. And again, when we were writing the textbook on biomaterials, it's impossible to neglect how important the immune system is. It's absolutely impossible. And as a histologist, doing a lot of histology as well as cell biology, we've learned that it's absolutely critical. And there's a few people that have really pioneered this field. This is one of them, Canadian Donald Brunette. And what Donald Brunette found, again, more than a decade ago, was that titanium implants that are implanted into the body is always, you see here, preceded by macrophage accumulation. And so some of the work that he's done is very simply, implant goes in, it's not a happy place where all of a sudden there's bone that's being formed. It's always immune system. And that immune system has to bind to these implant surfaces and figure out whether or not they like it or not. If they don't like it, that's when you have, implant loss. And if they do like it, then the immune system controls bone formation thereafter. And so those immune cells, like I said, are extremely important. And spending some time with Dieter Bossart in Bern, Switzerland, when we were working there, we wrote this article together called Osteomax Key Players Around Bone Biomaterials. And a lot of it was generated from his work. And it was all to say that osteomax stands for osteal macrophages, so that the macrophages living in bone. And the reason why we titled it Key Players Around Bone Biomaterials was that any biomaterial, whether it be a barrier membrane, a bone graft, whether it be a dental implant, everything is preceded by these osteomax. And they're the ones that's going to decide whether or not you're going to have an implant that's going to integrate or that's going to fail. And so the real key message here was that as we were doing research and then years will progress thereafter, we've realized that the most important thing in implants, or one of the most neglected things, I should say, is immune cell health. And by that, I mean, if your population is very deficient in certain micronutrients and vitamins that are very important for immune system health, such as vitamin D, which we'll get into a little bit later, those implants have a much smaller chance to actually integrate. And that was some of the work that we've done back in 2016 here. Now, macrophages are termed very plastic cells. And what that means is that they can be happy guys or they can be sad guys. If they're sad, or unhappy, they're typically titled M1, and that's here just represented dark side here, but it's tissue injury. Okay, so they go M1 and they go M2 when they're happier, and that's when they're regenerating tissues. Okay, so again, M1, M2. And just remember this because I'm going to show a study from Harvard where they've actually taken drugs where they can characterize more M2 and help tissue repair occur. Okay, so our job in Bern, Switzerland, and if you can imagine, we're working with some of the top clinicians of the world, Daniel Boozer, we're working with Tony Scullion, Klaus Lang, all these guys that have contributed very, very heavily to the field. And one of the things that we always see around titanium, zirconia, whatever implants you place here is always immune cells, and they can become multinucleated giant cells. They can do a whole bunch of different things, and they really dictate what's going on. Now, Tomas Albrektsson, so back to the main character and researcher who's really done a lot of work in this field, really characterizes these foreign body giant cells. So in some of his papers, he says, these are the guys right here that are really dictating what's going on with these implants. If the implant doesn't have the right surface topography, you can create more foreign body giant cells. And that's why he's always against using cheaper implants. And then, of course, this implant is now more susceptible to peri-implant breakdown. And your job as a clinician is to try and make sure that this immune system is staying as in perfect equilibrium, is the way that he defines it. And of course, if you have more bacteria, you know, your immune system is more inflammatory, so you get more breakdown. If there's less bacteria, of course, they're going to be a little bit happier. So it's all regulated. And your job as a clinician is to try and keep this in as best as possible in perfect equilibrium for the number of years that these implants are going to be placed. Now, how important is the immune system? These are two colleagues working in Harvard, at Harvard and Forsyth, and really, really smart guys, Thomas Van Dyke here and Alpkantarchi. And at Harvard, they created these molecules. And the molecules, the role of these molecules is simply to decrease inflammation. And they titled them resolvins. So you see it's published here in Nature. And these resolvins basically act by stopping inflammation, okay? And they've used it in dentistry as well. And the strategy now in the perio field, which I think is very interesting, is it's no longer, you know, try and take regenerative biomaterials such as Emdogain, PDGF, etc. Try and take molecules that are going to counter the immune system. And so this was published in the Journal of Dental Research. Very nice study. It was done partially at Harvard as well. Resolving macrophages counter osteolysis by anabolic actions on bone cells. And here, the way that they do this, and this can be around a tooth, it can be around an implant, it's the exact same concept. When you have these teeth, in these animal models, of course, to create more bone loss, they place a ligature, and the ligature breaks down the bone, and then you try and regenerate thereafter. So when you look at these models, you know, you can literally break down bone around these teeth or implants, and then you regenerate them thereafter. So here, 21 days, the animal wears the ligatures, and then afterwards, you try and regenerate these tissues. And what was very interesting in this study, and actually it was never done before, instead of using products such as PRF or Emdogain or any of these things, they used drugs that acted, excuse me, on the immune system. So here, one drug was going to eliminate macrophages completely. The other drug was going to create more of these happy macrophages, so M2 polarization macrophages here. And what they saw, which was very interesting, and it's, you know, very easy to understand when you look at these pictures. In these control animals wearing these ligatures, you had a lot of breakdown, so a lot of loss. When you actually used the drug that eliminated the macrophages here, you lost almost no bone. When you used the drug that actually made the macrophages happy, you lost a little bit more bone, but it was better than the control, okay? And so long story short, and one of the first things that was learned from this study, which is very, very important because this is going to be related to therapies in the future for peri-implantitis and periodontal disease, I'm sure. Here, if you make these macrophages happier, you're not going to lose as much loss around these teeth or these implants. But more importantly, and this was surprising, if you simply eliminated these macrophages, you didn't really have any bone loss. And that was something that was very highlighted in the paper and not really well known or well characterized at the time. It literally meant if you could just stop macrophages from doing their action, because these are the guys that are controlling. They're kind of the center and they're controlling bone formation, bone breakdown. If you could eliminate them or block them, you no longer lost bone. And the exact opposite was true when you tried to make bone. So here, the same two drugs were applied when you wanted to make bone. And interesting, okay, the control here is remaking bone. If you eliminated the macrophages again, you didn't make any bone. Okay, you had much more bone loss and it just stayed down. Whereas if the macrophages were happy with this M2 drug here, it would remake the bone. Okay, so long story short, conclusions from this paper: the macrophages in the immune system is totally responsible for bone breakdown and also for bone formation. And that meant that if you, as a clinician, so to speak, could somehow control these immune systems to behave more favorably, that's where you can really make more bone, and that's when you could actually stop bone. So if you could just wipe out macrophages for a little while, all of a sudden you would never not lose bone. And if you made them a little bit happier somehow, that would make more bone, okay? And so they really showed that the immune system is really in control here of what's going on. I work a lot with biomaterials. A lot of people don't know some of these studies that we've done over the years. And when you actually look at the osteoinductive phenomenon over the years, I published this work down here with UFUM, and it was funny. And many people still think this concept is true to this day. We talked a lot about osteoinduction, how to make more bone formation, and that's the field that we work in. And back then, we always said, you know, you need to have these stem cells that are recruited to the surface. You need them to differentiate into bone cells. You need to make bone formation in ectopic sites. And that was 10 years ago what we thought. And then in 2016, so, you know, about 5 years later, we started to realize, you know what, it's actually more to do with these immune cells. And after this was published, this work on Osteomax here, it led to some work that I did with Mark Bonner. And with Mark Bonner, he's a material expert. He actually figured out how to make biomaterials inductive, and it's all related to the immune system, okay? And when we finally figured it out, because for many years we had no idea, we actually published it in an impact factor journal that's 24. And for those that work in research know, of course, it's a very high impact factor journal. Most dental journals, the impact factors are between 3 and 5. I'll never ever publish an article that's this high of an impact factor. And the reason why is because this actually has massive impact on the whole field of biomaterials. And long story short, just to explain how this works, what was different than what most people thought at the time is that if you can actually make these biomaterials with subphysiological calcium and phosphate, that's how you drove actually the osteoinductive phenomenon. So I'm not going to go into detail of how this works. But of course, for those that want to know, like I said, you can read the article and I'm just providing it there. Now today, and this is a very recent article, 2020, it was published just a couple of weeks ago. Today, it's well known now that if you want to make these inductive biomaterials, whether it be around bone or around implants, everything is related to macrophages, okay? So this is leading edge research, like I said. For those that want to know more about these fields, these findings highlight here the critical role of macrophage polarization in biomaterial-dependent osteoinduction. And those are really good articles. Now, how does this relate to dental implants? And it's all correlated, okay? Whether or not you have bone formation that's taking place now, bone reduction, now we're starting to learn over years of research that it's all related to the immune system. And so this was one of the studies that I want to present as well. This was work that I did with a couple of young scholars at Michigan while I was living there, as well as Professor Homley Wang. And it's called Basis of Bone Metabolisms Around Dental Implants During Osseointegration and Peri-Implant Bone Loss. So how does this all relate now to implants and how we want to have our basis of bone metabolism and how we actually want to maintain these implants? And one of the things that we discussed here was the low vitamin D intake as being one of the key contributors. But more importantly here, we talked about the influence of, again, these immune cells as being discussed as being key regulators during dental implant osseointegration and maintenance. These cells are of crucial importance in the presence of biofilm accumulation and their associated byproducts that lead to hard and soft tissue breakdown, the so-called peri-implantitis. So this was work that we published in 2017 here. I remember getting the article that year, just saying that, you know, it was one of the top downloaded articles of the year between these periods, which was quite surprising for me, of course, because I was doing a lot of work with PRF and Emdogain, et cetera, in the fields that I work in, biomaterials. And of everything, you know, this is one of the ones that was being most read. And this was related to basis of bone metabolism. You know, I was really scratching my head, thinking to myself, I can't believe this is the article that people are reading most frequently. But the reality is that it's one of the ones that has the biggest impact on the field. And so very simply put, I mean, this is a no-brainer, but the reality is that vitamin D is very, very important for bone, right? When we talk about osteoporosis and having osteoporotic females in our clinics, the first thing that a medical doctor will do if you're becoming osteoporotic is give them vitamin D and vitamin K. And there's much correlation between having optimized levels and maintaining, bone health. And it has a lot to do with the immune system as well. Okay, and I'll share some of the data there. Now, the problem where I live, and it's probably more of a problem in Canada because vitamin D is one of these vitamins that absorbs with sun. It's the most deficient vitamin in the entire population. And so in the United States, of course, 70% of the population here is deficient. In Canada, it's probably around the same. In wintertime, it's worse. In any place where, you live in a place where it's colder, longer winters, less sunshine, you're going to be more and more deficient. And so it becomes very, very important because this is the vitamin for bone. And we're going to speak about the correlation between vitamin D deficiency and what happens with your implants now, because it's very relevant as well. So if you actually look online about vitamin D, it will talk about many correlations with many different diseases. And the reason why you see so many of these, such as Alzheimer's, cardiovascular disease, depression, diabetes, hypertension, very, very important diseases, it's all related to your immune cell health. And this is a powerful antioxidant as well. And the vitamin D is, when it's deficient, that's when you start running into all of these different issues. When it comes to the implant field, in 2009, one of the first studies came out on this, demonstration of vitamin D deficiency in an implant osseointegration rat model here. They do these pull-out tests where they actually, this is bone, this is an implant goes in, you try and pull out these implants and you look at the strength. And the strength of the implant pull-out test is 66% reduced when these animals are vitamin D deficient, which means that implant that go into normal bone, they integrate, they have a certain strength. Implant that goes into a vitamin D deficient individual goes through aseptic loosening, essentially, with 33% of the strength of a normal implant. Okay, it's very, very highly correlated here. And so Reinhardt, in 2012, again, another colleague that worked in Bern, Switzerland, published an article just saying very simply, that same paper in 2009, you could reverse this if these animals were simply compensated by supplementation. So it was very, very simple. He just proposed that all you got to do is get these animals or get these humans, get this population up to the right levels before these implants go in. And then the strength of these implants goes back up and you have proper bone implant bone implant contact, sorry. Now, Toby, again, the same guy who published on titanium particle release, did some work earlier in his career looking at vitamin D deficiency and early implant failure, 2 case reports. You started to see more people talking about this and it became more internationally recognized. These are the cases where you place an implant, and I remember in Bern, we used to call these slam dunk cases. So you have lots of bone, you got bleeding bone, everything looks great. Implant goes in, implant should be integrated, and then 4 to 6 weeks later, implant is a spinner. You're scratching your head, you're saying, how the heck did that implant fail? And you're saying, I used the same implant system that I always use. I did the same protocol. I did everything the same, nothing different. And for whatever reason, you're having nightmares at nighttime because you're wondering why the heck these implants failed. And the reality is, majority of the time, it's related to that host system, right? So when Thomas Albrektsson, more than 10 years ago, was talking about these implants being a foreign body reaction, that's exactly what occurred. That immune system in that patient didn't accept that implant. So it had nothing to do with that bone formation around that implant. It had everything to do with the immune system. And if that immune system is not properly calibrated, and a lot of that is as a result of vitamin D deficiency. So if you don't have this vitamin to the right levels, now all of a sudden your immune system's not behaving properly. That means you place that implant, those immune cells go to the implant and they're supposed to say, okay, we recognize this as being a titanium implant, call in the bone cells, make bone. If they're dysregulated because they're not properly controlled with the right vitamins, they're not behaving properly, and they see these biomaterials and they say, you know what, I don't like this, I'm not feeling well, on and on and on, implant goes out and gets spit out of the mouth. And that's what happens. And I always tell people in our courses, if you're not one of these clinicians that actually checks vitamin D deficiency, after that implant has an early implant failure, I can almost guarantee you 99% of the time, you tell that patient, go get a vitamin D check, go get a $79 vitamin D check, and 99% of the time they're going to come back deficient. Okay, it's very, very highly correlated. Now, Professor Mangano from Italy did this study, and it was a nice one because finally it was a big study with nearly 2,000 implants and close to 1,000 patients here. And he was looking at the correlation between vitamin D and implant failure. And what he found was overall 4% failure rates here. Heavy smokers, 6%, so about 50% increase. Generalized perio, again, from 4% up to 6%. Vitamin D deficiency, 11%. Okay, and when you look at the numbers, 4% to 6%, 2% increase, that's about 50% more, whereas here you have almost 300% more. And the moral of this paper, and the reason why it was very relevant and highly cited, was because vitamin D was more related to implant failure than smoking or generalized perio. And that's actually crazy when you think about it, because how many clinics actually will not place implant in smokers or heavy smokers? In this paper here, defined as 15 cigarettes per day. I mean, that's a lot. So if somebody comes in smoking 15 cigarettes per day, you're saying, hey, wait a minute, you got to sign this form here. But all of a sudden, if you're vitamin D deficient, and a big population is, your implant failure rates goes up almost 3 times higher. Okay, so it's much, much more important to know what the patient's vitamin D levels are when compared to how much they smoke. And in fact, in a perfect world, if you wanted to place an implant and you're having your medical forms that are filled out in your clinic, one of the questions should be, have you tested your vitamin D levels recently? What are they? Mark it down, and can you show it? Because that's how important it's becoming with respect to these levels here. And it's funny, right? For those that are following a little bit of the COVID pandemic, one of the things that the CDC released was that they talked about, the facts and realities, and they recommend for anybody that wants to try and prevent having COVID today, they say take vitamin D, because vitamin D deficiency is a global pandemic. We know that. Vitamin D is proven powerful immunomodulator. We've discussed this now. We lose nothing by improving the global vitamin D status, as foods do not have enough. And so you actually require supplementation. And this is becoming a very, very big thing. I think today, if you're a clinician especially, and you've not checked your own levels, definitely do it, because it will help defend you against COVID. And they've really shown statistically now that patients that are deficient in vitamin D have a higher mortality rate with respect to COVID. Okay, and it's related to the immune system here. Now, the guidelines, very straightforward. These are published every 2 years or so. I live in the United States, so I follow the United States recommendations, but they're about the same everywhere in the world. Anybody that's above 30 is considered non-deficient, so that's the ideal levels, with the preferred range between 40 and 60 nanograms per ml. And ideally, you should be taking 1,500 to 2,000 units per day. That's when you're at the right levels. If you're deficient, you need to take a lot more to get back up to the right levels. And for obese people, of course, you need to take sometimes up to 3 times more. Okay, so everybody's got to be a little bit customized. People absorb these vitamins a little bit differently. If you are deficient, typically what's recommended is you take 5,000 units per day for 12 weeks. Okay, so that's the general recommendations from the Endocrine Society here in the United States. Now, vitamin D, you don't necessarily need to go get it checked at a testing center, okay, by doing a blood draw. Vitamin D today can be checked very simply with a simple finger prick. And much like you can get a glucose reading, so if you have a diabetic patient that comes in, you take a little finger prick, you say, okay, your levels are okay today for us to do surgery together. You can do the exact same thing with vitamin D. So you can take a little finger prick, you can get your reading, and this is available now to clinicians for the last 4 or 5 years in Europe and for the last year or 2 in North America. And we use this very heavily, okay? It's very straightforward. It looks exactly like the COVID test. So for those that use the antibody test, at least, it's the exact same phenomenon. The sample goes in with blood and a buffer, and then you get your readings here. And there's a little measuring device here that does this. I'll go through this very quickly here. For those that have never seen how this is done, again, you put a little alcohol here on the finger, and then you can get a little drop of blood. You collect the blood sample, and I apologize for going quick. I just don't want to waste time with this. You put it in the sample, and then, of course, it's going to rush up. There's the control, and the test band is slowly going to get darker and darker the more vitamin D you have. And the little vitamin D reader here, there's a little cube reader that you're going to place over top. This little cube reader is going to make the measurement for you. Okay. So in this case here, it's there's two types. There's one that lasts 15 minutes and one that's 10 minutes. So the test. So here you put it on. There's a 15-minute test here. And as it goes down, okay, here 50.2 nanograms per ml. So this is somebody that works in our lab and are part of our team here. And 50.2 is between the 40 to 60. So people that work with us understand how important it is. And we always check, every 3-4 months to see where we're at. So that's one thing that's very, very important to regulate immune system. The other one, of course, is with antioxidants. And I'm going to share with you guys some work that was done by various colleagues that is also very important for the immune system and their health, as well as around these peri-implant tissues. Antioxidants. When you have any kind of stress in your body, whether it be from radiation, alcohol, smoking, etc., always remember that when you have, for example, a cell, this cell has a nucleus with all the DNA, and radiation wants to damage the DNA and cause mutations, which will cause cancer. And what blocks the radiation from actually getting to the nucleus are all these antioxidants. So they prevent oxidative stress and oxidative damage. And the antioxidants basically shield and block. The more you have, the less chance you have of having damage, the less chance you have of having cancer. Okay, it's very, very straightforward. They're very, very important. And you get, of course, antioxidants from vegetables and from fruits, and you can supplement as well with these. Reality, again, here, the majority of the population is deficient. Okay. Now, it was actually Pat Allen and a couple of other colleagues here that wrote, and they've developed a specialized formula with respect to antioxidants for periodontal disease. And they just said, in general, antioxidants may be available through oral ingestion, diet, or supplements. And this review focused on the relationship between antioxidants and free radicals. Okay. And Pat Allen is somebody that I respect tremendously because of all the work that he's done in the perio field, as well as this colleague here, Ian Chappell, who's from London, UK. And they found exact same thing. For prevention of periodontitis, daily nutrition should include sufficient antioxidants, vitamin D, and calcium. Inadequate antioxidant levels may be managed by higher intake of vegetables, etc. Okay, or you can take some supplements. This concept here is the exact same thing, whether it be a periodontal tissue or whether it be a peri-implant tissue. Okay, when you have periodontal disease or peri-implant disease, one of the key things is that immune system, as Dr. Albrektsson discussed, is being dysregulated. And your job as a clinician is to try and, optimize this as best as possible. And one of the ways that you can do that very straightforwardly is through these supplements, essentially. And so again, you look at the general population, we're very, very deficient. The one that we're most deficient in is vitamin D. And when we started to look at all of these different things, that's when DentaMedica was created. And I think, a lot of the population knows about this now, but I think some people have never heard of it, for one, though there's been some articles that have been written on this topic. But more importantly, what is it and what is its role in whether it be periodontal or peri-implant diseases? The fact is that whether you're going to place an implant today or whether you have all these patients, we have so many patients that are deficient in all these micronutrients. And now there's a very strong correlation between implant failure and things like vitamin D deficiency. The question now is, why would you ever place an implant in somebody that's deficient in vitamin D? I mean, it doesn't really make a lot of sense. And again, when there's peri-implant breakdown, those are the people that need supplements and to be at adequate levels the most. Same thing 10 years ago in the periodontal disease with Pat Allen's work and all of the colleagues, Ian Chappell, when they started supplementing their patients in periodontal field, the same thing should be occurring in the peri-implant field. And this was something that was developed, it's a US, so it's not available in Europe, but it's a US-based company that is from California that develops these supplements that are GMP grade, so they're medical grade facility supplements to basically boost the levels of these implant patients. And so you take a supplement in the morning and evening, and we do this with our patients before implants go in for anybody that's deficient. So we test all of our patients. And then afterwards, we do the same thing. If somebody's has rapid periodontal or peri-implant breakdown, these are the patients that you basically want to supplement to get them to the right levels, and they take this twice per day. Now, we've done a lot of work with this in United States while I was in Florida. And more recently, a very good study was actually done at the White Clinic. And this is a clinic that's in Portugal, and it's led by Miguel Stanley. And he had one of his young researchers, Dr. Ana Paz, do the study. And in the study, there was a few things that they wanted to address. Number one, how effective are these testers? So there's different kinds. These are the finger prick tests. You have one system that's European-based, Rapid D. You have another system that's US-based, Test 4D, and test them both compared to whole blood. And then they had another device that measures antioxidants, and they did this study. So when you actually look at the data, it was very interesting. Vitamin score. So these are the lab vitamin scores in blue here. These are the Rapid D, so that's the European one, and the Vitamin 4D, that's the US-based finger prick test. And you look at all the data, so these are all the different patients here. They're all very similar. No matter what the patient is, it's all very similar. So actually, these little devices that are in office that you get a reading from in 10 minutes are as effective as doing a blood lab test. So that's been confirmed. And we've done our own work too. We found that it was around 94% similar. So it's great for screening. Okay, that's the bottom message here. It's absolutely fantastic for screening, number one. Number two, you can actually charge patients for this, right? Before you go into an implant surgery, we charge them $59. And then we get the reading, which is very important for these surgeries. And then depending on their scores, we then decide whether or not they need supplementation or not. And to be quite honest, since 70% of the population is deficient, you're going to have to supplement these patients most likely. And when this study was conducted in Portugal, we had around 70% deficiency, and that's in Florida. So that's exactly where I'm living. They had 82% in Portugal deficiency in vitamin D. So this is internationally, this is probably the vitamin that's most deficient, but it's the one that's most correlated with bone. And this is before supplementing in blue here, and this is after, and you can see every single patient went above the 30, and a lot of them went into the preferred range, and this was only 4 weeks after. Okay, so it was the way that these supplementation guidelines work. You basically just package it up in a supplement package, the DentaMedica. These patients will take it 4 weeks before they go into an implant surgery, 2 weeks afterwards. Okay, it's like a super dose of these supplements. Anytime somebody's going to go through peri-implant therapy, it's the exact same thing. I don't want to do a peri-implant therapy, so to speak, if that patient isn't optimized with the right immune system and the right balance, because I'm lowering my chances. So for very cheaply, these supplements are less than $100. You can pump your immune system up in that patient, and then you go into whether it be peri-implant treatments, etc. Okay, and when it came to antioxidants, 35% of the population was deficient before supplementation, and then everybody went to the right levels afterwards. So again, the vitamin D one is really the one that most people are low in. Like I said, it was 82% deficient versus 35% deficient in antioxidants. Okay. In certain populations, you might need to actually supplement them longer than you would have hoped for. So usually the DentaMedica guidelines is 6 weeks before, it's a 6-week program, 4 weeks before surgery, 2 weeks afterwards. So whether we're doing peri-implant therapy, whether we're placing these implants, you take the supplement 4 weeks before, you pump up your immune system, and then because surgery is stressful for the patient and they go through some oxidative stress, then they take them for 2 weeks after, and then you're done. It's a super dose. Then they can go back to taking regular supplements, etc. But in smokers and diabetics especially, that's where you got to be a little bit careful, okay? I highly recommend you do the testing of the vitamin D for these two populations here because they're more deficient than most. For those, I'm going to finish up here. For those that are not aware of all the work that's been done in this field, I highly recommend reading an article that was written by Dr. Scott Froome. It was published in February this year, 2020. Vitamin D deficiency, impact on wound healing and implant failure. And I think he's written a very beautiful article where it's very well described in a very simple to digest for dentists. Okay, sometimes when I write articles, they're a little bit more in detail and a little bit more complex to read. And I read his and I said, man, this is like bulletproof. It's just fact, all the way down. And then I had the opportunity to write an article here with Michael Pikos, who's in Trinity, Florida, and a very close collaborator of mine and somebody that I enjoy working with very much, as well as Dr. Mark Bishara, of course, up in Canada. And in this article, it was published in April 2020, so about a month ago. And the reason why it's funny that we're having this symposium now, we wrote this article maybe 7-8 months ago, and finally it came out in print. But the reality is for the last year or so, we said, there's too many clinicians that don't know enough about this topic. This would be a nice article for Dentistry Today. And it was titled Vitamin D Deficiency and Early Implant Failure, What Every Clinician Should Know. Okay. And it just talked about, you should know that you can actually do these testing right in your office. It's not very hard. It's straightforward. Okay. Number one. Number two, you should know that these are the guidelines. This is the range that you should be. And you should also know the failure rates of these implants, which are 4% versus 11% in these vitamin D deficient cases. And Dr. Bishara actually put a case in where, it was a nice case. It was straightforward. It was done in the middle of wintertime up in Canada. You got lots of bone, you got bleeding bone, the implants go in, and then everything looks great. This is the periapical taken immediately after the surgery. And then 1 month later, this is what's going on. And you're sitting there scratching your head saying, how the heck did this happen? And the reality was, it's very simple. You send this patient for a vitamin D test. This patient's critically deficient in vitamin D, and that's the reason for these implants that are failing. And what we do with these patients, of course, is we graft, we supplement them to make sure their levels go back up, and then you can place the implant. This is as a result of a foreign body reaction. They're not allergic to the titanium or anything. This patient was not able to receive these implants because his immune system and his immune cell health was not optimized for these cases. So always remember that before these implants make bone, it's always immune system come around these implants ahead of time. This is the absolutely last thing that I want to finish up with. This is a paper, again, back to Tomas Albrektsson, the guy that's been doing this for more than 10 years. This was published, look at this, 2020. It was published a couple weeks ago, okay, in JOMI. And now he's talking about an imbalance of the immune system instead of a disease behind marginal bone loss around implants. And results, evidence is presented that commercially pure titanium is not biologically inert, but instead it activates the immune system of the body. And in reality, bacteria actions are secondary to an imbalance of the innate immune system. Okay, so everybody's starting to learn about this. Everybody's kind of getting more and more into that. It's a lot to do with the immune system, and so it's becoming more and more relevant. You're going to see presentations from the second speaker that's going to talk about titanium particle release, how important that is. And again, that's related to when those little titanium gets released, it's going to cause inflammatory response in the immune system. And now it's an imbalance now. The same thing, I'm sure when you hear Tomas present a little bit later today, this is Tomas Linkevicius, of course, he'll speak about things like cement, excess cement. What is it? What happens there? It's not bacteria induced. It's an inflammatory response, and it's now an imbalance between the immune system. So to finish up here, never forget how important the overall health is in your patients, as well as how important the immune system is prior to and during the maintenance of these dental implants. So that's everything. I want to thank all the collaborators that helped with the research that we've done here. I'm going to pass it back over to Dr. Bishara, who can present the next presenter. Thank you.
So Rick, that was a fantastic presentation and a nice segue into our next presenter. And I think it's so important to understand that these complications can happen at any stage of treatment. And that's actually part of the reason we've developed a whole section devoted to implant complications on the forum, because we need to understand at what point of treatment these failures can occur. And in this presentation, the focus was on the biology side. And now that we're leading into the next segment, I think this will be a perfect segue into that. So I'll let my co-host and other moderator introduce our next speaker.
With huge pleasure. Actually, he doesn't need any introduction. He has 10 pages CV, 1 page awards, and 8 pages references, one of them in Lancet. As you can see, George, show your profile. He is from Athens. He graduated in Athens, and his training he has done in the States, Minnesota, then Washington, and finally he's in San Antonio, mentoring, doing clinical work, and the director of the research lab. And now my friend, Professor Kotsakis, is going to tell us why and how degradation, biomaterial degradation products makes macrophages unhappy. Be excited.
Well, thank you so much. This is really a wonderful introduction and an honor, and it's definitely an honor to be here with you all and some people who I think are real authorities in peri-implantitis today. It's just an amazing lineup. And a little bit of how this started is in the pre-COVID era. We had talked with Mark about potentially doing a hands-on course on peri-implantitis management up in Canada, and that's how everything started. But then COVID hit us, and as part of adapting, I think that evolved into something really nice, a full-blown peri-implantitis complication symposium. And Rick did a terrific job tackling the biology. So now I'm going to transition and talk a little bit about how I think our latest evidence talks about how this can be translated clinically, both into prevention and management of peri-implantitis. So these are a lot of folks that have supported our research through the times. And as you will see during the entire presentation, I'm really, some would say obsessed, but I would rather say motivated towards evidence-based dentistry. So what I'm going to show you is really a compilation of all the work that we've done for almost more than 5 years now on peri-implantitis research. Now, what's exciting, and it's very attractive to the field of peri-implantitis research, is that it is so new. Just to put this into perspective, the first time ever we had a formal classification of peri-implantitis, peri-implant diseases and conditions was in 2017 out of the World Workshop in Periodontics. And I had the great honor to be the one, along with Dr. Jim Heinrichs, my old program director at Minnesota, to put this together in a chapter in Carranza's Clinical Periodontology. So what this new classification concluded is, first of all, we have a definition. And peri-implantitis is defined as an inflammatory process in the tissue surrounding a functioning implant characterized by loss of peri-implant bone. Okay, so the cardinal features are inflammation, functioning implant, which directly translates into exposure to the oral environment. And as you all know, being dentists, there's a ubiquitous presence of bacteria in the oral environment. So really, when we're talking about a functioning implant, we're talking about a bacterial challenge. And then characterized by loss of peri-implant bone. So that means that it's destructive inflammation. So the 4 corollaries for diagnosis of peri-implantitis now, according to the latest classification, are, first of all, visual inflammatory changes. And one example here, you can appreciate how severely swollen the tissues are around one of these implants that I'm being called to treat for peri-implantitis. And then this swelling is combined with either bleeding or probing and or suppuration. And I want to tell you that just in the preceding discussion, the preceding lecture, we heard a lot about the role of macrophages and inflammatory versus resolving macrophages. But one of the characteristics that really makes for a very unique disease in peri-implantitis versus periodontitis is that we have very, very little access for these immune cells, for leukocytes in general and macrophages in particular, to reach the implant surface, because we're lacking the massive blood supply that comes through the periodontal ligament around teeth. So in terms of disease manifestation, disease manifests way faster. We lose bone way faster than we do with periodontitis. And we see different symptoms, signs like suppuration, like pus coming out way more often than we do with periodontitis, when periodontal abscesses are not as common. And then what we need to do to diagnose periodontitis is assess increase in probing depths. Now, that is easy to say if you have a baseline, but if you don't, assessing probing depths around implants becomes a very, very tricky thing. As you can appreciate here, we have 5 implants placed for a fixed detachable in the mandible, and all 5 of them are placed in a different apicocoronal level. And what that means is that when you consider the position of the implant platform as that relates to the bone crest and the supracrestal tissue attachment, the individual phenotype of supracrestal tissue attachment each person has, then we're talking about an individualized, healthy reference probing depth for each person. So if you think about it, placing an implant in the posterior mandible where tissue is usually thinner, right at the level of the bony crest, and maybe having about 2 millimeters of keratinized mucosa over that makes for a healthy 2-3 millimeter baseline probing depth when that implant gets loaded. Now, think about having mild to moderate periodontitis on number 8. That's for our Canadian colleagues. That's a central incisor in the maxilla, and having to extract that tooth, having slight deficiency in the buccal bone, and lack of primary stability. So we end up placing the implant deeper than expected to compensate for these factors. So now we end up having a baseline, a healthy reference probing depth for this side of 5 millimeters, which would be, of course, consistent with disease around teeth. But here, it's very important to understand that it's customized, it's person-made, and the surgeon actually determines what this is. So when we want to assess progressive bone loss or progressive probing depths, that becomes very challenging unless we have a healthy reference. That's why, as part of our new diagnosis and classification of peri-implantitis, we have a specific cutoffs, and that is a cutoff of bone levels of about 3 millimeters and probing depths of greater or equal to 6 millimeters, along with signs of inflammation to diagnose peri-implantitis. That's why, if you're not already doing this, I highly recommend to embrace the concept of an implant passport. So when, let's say, we go to an orthopedic surgeon at the hospital setting to have a hip or a knee replacement, then it's customary, or in some countries it's actually mandatory, that for every implant that is placed in a person, that gets accounted for and a patient card is dispersed. And I've kind of borrowed this concept of the surgical orthopedic implant patient card, and I've adapted it in my dental practice. So what that means is that every patient gets an individual patient card that has vital information for, first of all, tracking health versus implant disease, and second, for giving us the ability to either repair or redo the prosthetics of that implant. Because, for instance, I do a lot of peri-implantitis management in my practice, and when I get an implant that has a history of peri-implantitis and I need to treat it, the first question that I ask is, well, what if restorative contours? What if the fabrication, the form and the shape and the positioning of the prosthetic restoration are part of the problem? Do I have the capability to change this? Do I know what the implant brand is? Do I know what the diameter is? Do I know what screwdriver I'm going to need? And in terms of determining if this is disease or not, we know that there are specific risk factors, and I'm not going to get into that because Dr. Vergoullis and Dr. Linkevicius will talk extensively about this. But for instance, if we have a methacrylate cement, that vastly increases risk for peri-implantitis. This information needs to be registered, and if a patient moves or changes practices, I need to know what has happened. So I highly recommend that a patient card is given, and that patient card includes information up to and including probing depth at loading. Not at the time of placement, of course, but at the time of loading or shortly after loading of the restoration. Now, let's see a clinical case of peri-implantitis. What's typical about these cases, although not always present, you can appreciate this slight porphyr bluish hue of the mucosal color above the canine implant, and you can see the slight edema, the bulbous papilla here. So we have visual aspects of inflammation. Of course, it goes without saying that appropriate monitoring of peri-implant health happens with a periodontal probe and not only visually. It is very well established. The periodontal probe, even a metal probe used with appropriate force, will definitely not compromise the epithelial attachment on that implant. And even if that attachment is compromised, in clean conditions, it can repair itself within 3 to 5 days. So peri-implant probing will give us, in this case, a probing depth of about 8 millimeters. You can see the linear bleeding on probing. So clearly, this is a case of peri-implantitis. And now the real question is, how do we manage this? Now, in order to manage a disease, the first thing you want to know is what's the cause of disease. For instance, if I just go to the doctor and let's say I have diabetes mellitus, and the only thing they do is that they measure glucose levels in my blood. right? They don't know if this is an insulin-dependent form of diabetes, if it's type 1 diabetes, or it's associated with resistance to insulin if it's more of a type 2 diabetes. So really, unless I figure out the exact cause of that clinical manifestation of the symptoms and signs of disease that I'm looking at, I can't really reverse them and treat disease. So the first important question we have to ask is, what causes this inflammatory and distractive inflammatory process around implants? And I'm saying distractive because it causes vast loss of peri-implant bone. And just because we know so well what bacteria can do to teeth, and we've known how to manage this since the early 80s, really. Since the early 80s, the non-surgical treatment of periodontitis has been really established, and we know that results can be remarkable in a lot of cases of periodontitis. So as a result here, it was originally thought that peri-implantitis was very similar to periodontitis, because it was also a result of an overwhelming bacterial insult. And here you can see a scanning electron microscopy, an SEM microphotograph that we've taken. This is about 1000x magnification, and it shows you all these different morphotypes of bacteria that are inhabiting a biofilm on a titanium implant. And as a result, what are we doing to treat it? What do we know to do very well around teeth? We use abrasion to remove that biofilm from the implant, right? The biofilm that I just showed you. So the direct translation of this has been, instead of steel curettes, now using titanium curettes. Instead of using metal ultrasonic tips, we're using carbon or titanium coated ultrasonic tips, and then titanium brushes that have finer bristles that can hopefully go in between the threads better than the very wide toe of a curette can. And of course, chemotherapeutic agents like chlorhexidine, for instance, which goes without saying, it kind of goes with every non-surgical periodontitis treatment around teeth. Now, in 2012, a very definitive, a Cochrane systematic review was published by a very well-respected group. And what they reported was shocking. And I kind of call it the death of the titanium curette study, really, because what they found was that existing at the time antimicrobial peri-implantitis treatments, either via chemotherapeutics or via mechanical abrasion, had up to 100% relapse after 1 year. And to put this into perspective, how likely it is that you're going to go to your dentist or your medical doctor's office and for a procedure, and you're going to ask them, what are the chances that I'm going to have resolution of obviously non-fatal disease a year later? And they tell you, well, we can have up to 0% success rate. Well, likely you're not going to go through this procedure. You're going to opt probably for explantation, for removal of that implant. And what was very interesting in this study, if you read the whole thing, their conclusion came out of 4 clinical trials primarily. And they found that the more complex procedures to remove biofilms, targeted biofilm elimination, really didn't do much better than just using cotton pellets soaked in just water, sterile saline, or even plastic curettes. So now, after this, after about a decade of research on the causes of peri-implantitis, we clearly understand that it is a multifactorial disease. And what happens in a multifactorial disease is that you have to think about different component causes. And I have 4 different causes here. And for instance, excess cement, restorative contours, plaque biofilm, or abrasion of the implant surface and titanium corrosion. And it's unlikely for such a complex multifactorial disease to be caused by a single agent, by a single causative factor. So usually we have a lot of component causes that have to somehow coexist, co-occur for a specific individual to create a sufficient cause for disease in the specific patient that you have in your dental chair. The point I'm trying to make here is that every single case of peri-implant diseases that we encounter likely has different etiologies or can be roughly categorized in different groups of etiologies. And in terms of excess cement and restorative contours and position of the implant platform in relation to the bone and the supracrestal tissue attachment, we have an amazing team that's coming up in the second segment with Tomas and Ioannis. They're going to talk extensively about this. So today I'm going to focus on plaque biofilms and titanium particles and talk about how these can come into play with peri-implant inflammation. So when we're thinking about scaling and how scaling, I showed you, completely failed to treat peri-implantitis. We had up to 100% relapse a year later, as published in 2012. We have to think about what scaling can do around implants. First of all, you can clearly appreciate the complex macro geometry of the implant. You can appreciate the threads, and usually in most implant designs, the pitch of the thread is not wide enough to fit curettes in there, particularly when that happens non-surgically in a blind fashion. I mean, the thought alone that you can put this big of a titanium curette non-surgically into the peri-implant sulcus, and just by going up and down and doing scaling strokes, you can remove the biofilm from a titanium threaded micro rough or sometimes nano rough surface is kind of naive. So we know that they are generally mechanical approaches are unable to effectively clean implants. And the other problem is that they might as well have titanium surface effects. Now, in this particular case, we did non-surgical treatment as part of a randomized controlled trial we're running. So I don't know exactly what means of non-surgical treatment we employed, but I know we did non-surgical treatment because I can't break the randomization at this point. But what's really cool about me working in an academic setting is that we have the ability not only to indirectly assess the efficacy of our cleaning by the clinical signs of disease and inflammation, but we can also probe more into it and do specific assays. For instance, here you see a plaque biofilm assay where we just collect whatever's left behind in terms of plaque on that implant, and we can stain it. And this specific stain, it's called the live dead stain, and it's very simple. And I'm going to explain what it is because it's critical for the next step. So anything you see painted green here is live biofilm bacteria, and anything you see red is dead bacteria. So you can clearly see here that we have a very robust, a layered, a thick biofilm with a lot of different shapes and types of bacteria left behind after non-surgical cleaning. So what this did is it's prompted us really to assess the efficacy of different approaches, because as you know, there's a lot of instrumentation available for cleaning implants mechanically. And the majority of it is based on the concept that we really have to scrape off. Same thing as we do with scaling and replanting around teeth, we have to scrape off the biofilm. And here we compared a control group that's all the way to the left. So you can see everything lights up green. So that means that on that implant, after I'm doing nothing, I just have peri-implant bacteria, everything lights up green. And if you remember from your microbiology at school, this is called an agar plate. And we simply try to see if we can culture, if we can regrow bacteria from that implant surface after we clean it, which is, of course, kind of a surrogate for saying, okay, after I'm done with my cleaning procedure clinically in real life, are there enough bacteria left behind to regrow over the implant surface and cause a problem? So you can appreciate, first of all, we have a chemotherapeutic control, chlorhexidine, and you can see that what chlorhexidine does, very consistent with biofilm studies, is that it kills a lot of this bacteria. You can see a lot of red or orange signal lighting up now, but it makes them stick on that surface. And you can do what I call the chlorhexidine test. And by that, I mean that you can go ahead and pour a little bit of chlorhexidine on your latex gloves or non-latex gloves, and then 10 seconds later, try to do this. You will see that they stick. It's like glue. So what chlorhexidine does is that it forms an organic coating over the surface and makes all the dead biofilm stick to that surface. And if you remember anything about immunology, it's not the live bacteria per se that secrete proteins that cause inflammation primarily, but the primary means is their dead surface debris like lipopolysaccharide, endotoxin. So chlorhexidine, for those who have looked into it, it is clear that does very well for preventing formation of biofilms and for killing planktonic bacteria. For instance, I'm doing scaling and replanting for periodontitis as a periodontist, and then I recommend chlorhexidine for a couple of weeks to prevent bacteria from the tongue or from the cheek or from the tonsils to repopulate these cellular reservoirs. But against established biofilms, chlorhexidine really has a very moderate effect. And as I said, it kind of makes everything stick behind. And then you can also see the titanium group, the titanium brush group here. And the titanium brush has little bristles that are rigid coming out. And this pitch of the bristles kind of tries to replicate, in a sense, the pitch of the threads of the implant. But you can obviously see here that wherever that bristle touches the implant surface, I have kind of an empty area of biofilm removal, and everything else stays behind. And you can see proof of how bacterial colonies kind of regrow after this procedure very well. And then, lo and behold, you look at the water jet irrigation of the implants, and you see near complete elimination of the biofilm. You see very, very little sporadic leftover bacteria with the high or low settings here. So that when we saw these results, that absolutely changed our perspective about what we really need to do around implants. And it doesn't have much to do with what we're doing around teeth. So the titanium brush, that is the best available abrasive tool for removing biofilms, kind of does a very poor job when it comes to removing biofilms for implants. And then you look at a nylon brush that's way softer, and by being softer, it's able to conform and adapt better in between the threads and along the geometry of the implant surface, and does quite a decent job in reducing that microbial load. And the pressurized water, the pressurized saline here, nearly eliminates any remaining bacteria behind in a much more impressive fashion than any other group. So I have a little video from one of our hands-on courses here about what we now do. So this is one of our peri-implantitis model surface, and we're going to try to go ahead and clean this surface using pressurized water. So we're going to
Mark, do you have audio?
Unit.
Yes.
And you can note that we actually have a rheostat to determine the pressure, the PSIs that we're going to use. We've tested this both at low settings and high settings, and have found only minor differences in the removal of the biofilm. So it's really potent even in the very low setting. So usually what we tend to recommend is kind of the mid-level setting. And we turn on the unit. You see the handle is still in the off setting. So we will first position, and that will be the analogy to the patient's mouth. We got to do that non-surgically. That's why we're using the pickpocket tip that goes actually submucosal around the implant and clean. And once we're at the right setting, we will initiate and start pressurized water irrigation. So. And this is really an outside of the box thinking of an approach that could be the future in non-surgical treatment of implants, because the surface coverage that you get by really pressure washing that pressurized saline, the pulsated pressurized saline motion, is way more. You just cover way more of the implant real estate than you could with any very surface specific mechanical instruments like the titanium curette or the titanium brush. So the next, first of all, we kind of showed that we have to think outside of the box and design implant-specific tools, implant-specific tool aids to be able to clean these implants. But then again, how about if we have titanium surface effects? And this is where we really got to think outside of the box and think beyond the periodontal infection model. And as Rick very nicely talked about before, how about a paradigm where implant surface properties, according to the Albrektsson work and the Olmedo work, have a lot to do with inflammation around implants. Now, because we coordinated with Rick before, and I knew he would present the Albrektsson work and the Fredworth work, I want to show 3 studies that I think have had just a profound effect in the way peri-implantitis is managed today. And the first one was Olmedo in 2011, and he showed a proof of principle concept that macrophages, they recognize titanium. What you can see here, these are macrophage cells and these are titanium particles. And these macrophages rapidly, they recognize it and they internalize, they phagocytose it, as we say. And they have a profound inflammatory response. Because we had such a nice discussion about antioxidant properties before, you can appreciate here there's a stain. What the dark color is, it's an NVT stain that stains oxidative stress of the cells. So that's what happens. And once we have oxidative stress, that's what initiates the pro-inflammatory signaling cascade that leads to what we all know as a major bone destructive cytokine, IL-1 beta, interleukin-1 beta. So that first proof of principle was that titanium particles, as it has been clearly shown in the orthopedic literature, they have a pro-inflammatory role. So if they're present there, they can trigger inflammation even independently of bacteria, because when it comes to orthopedics, when you have a titanium hip replacement, that's aseptic inflammation. It's called actually aseptic screw loosening. And just a little point here, this has nothing to do with allergy. We hear a lot of people talk about, allergies to titanium. Absolutely nothing. Innate immunity has very little to do, macrophages, M1 macrophages specifically, as in this case, have very little to do with allergic reactions. This is really an actual inflammatory, chronic inflammatory response. So allergies exist for pretty much everything, especially if you're here in Texas, oh my God, all year round. But what is very interesting for implants is they're really bioinert. If you have titanium and you put a little patch on the patient's neck, very, very few people, about 1 in 1,000, will have an allergy to titanium, or even less. So this is really a chronic inflammatory response and not an allergic reaction. So what was done here in this study, the second critical study that I consider, the study by Safiori et al., this study had already started by Diane Dobert, who's done some tremendous work on peri-implant research and the role of titanium particles up at the University of Washington, even before I went there. And it was already started by one of our residents, Dr. Safiori. So I became part of this study. And what we found, and Dr. Safiori won the Clinical Research Award by the American Academy of Periodontology for this research that she presented, is that when we had healthy, and you can see healthy implants on one side and diseased implants on the other side, significantly greater levels of dissolved titanium were found in the submucosal plaque. We're talking about titanium trapped within the plaque where bacteria are, in peri-implantitis as compared to health. So you can see here, this is a chart of just measuring plaque biomass, and the first bar, the red-orange bar, is the healthy bar. And then the blue bar is the peri-implant disease bar. So comparing the two, we had about double as much plaque biomass in disease as compared to health. Okay, and this is consistent with what we know. Bacteria are always going to be around implants, but when we're going to have way more bacteria than the immune response in the area can tolerate, that might lead to dysbiosis. However, results were striking when we looked at titanium concentrations within that plaque. And we found something that is way closer to a causal association than this plaque effect is. And I'm saying why way closer, because in health, titanium levels were near zero. You can see this area right here. So we could barely detect titanium around implants in health, which means that titanium implants are very resilient, very robust. They don't leak titanium. But because of an, at the time, unknown mechanism, in disease, we have a nearly tenfold increase in titanium particle levels. And then what I did, because I like numbers, but I really believe in visual, is I got plaque. This is part of another resident's thesis work. This is Dr. Jason Kuhn, who just graduated with his master's from the University of Washington recently. We got together, we got a plaque sample, and we processed it for transmission electron microscopy. So that's kind of really thin slices that we're able to see at about 1,000x again here, or even more. You can see that the scale bar, this is about 50 nanometers. This is how close we can get. And you can see these black dots within the plaque matrix. And when we zoom in and we check for their metal composition, we find that we have very, very strong titanium signal. These are titanium particles, and you can see how they look like. This is about 200 nanometers of a titanium particle within the plaque matrix. So now we know that we have the proof of principle from Olmedo. If a titanium particle is there, it's going to be recognized by macrophages. Actually, there's work showing that it will polarize naive macrophages towards the M1 route, the pro-inflammatory route, and will cause inflammation. And now we have actual visual and quantitative findings that it is there. And then the third study that I think really has reshaped the field of peri-implantitis management was this one by Eger et al. From Israel, and came about at the same time as our Safiori et al. Study. And they did something very simple, but still unique, because no one had done it at the time. They got a regular ultrasonic tip that we all use in our practices. And whenever you have an implant patient, a person with a mixed dentition, right? Mixed dental implant dentition, coming in for a cleaning, what you're going to do, or the hygienist in your practice is going to do, they're going to get an ultrasonic and go around all teeth to get rid of the plaque. And sometimes, just sometimes, the ultrasonic tip might as well touch the implant. So this here shows you what we get in the water that's coming out from the ultrasonic tip, from the irrigation, after 30 seconds of using that ultrasonic tip to clean an implant. And what you see right here is titanium particles that have a particle range from about 1 to 15 micrometers, which is well within the vicinity of what a macrophage can recognize and can engulf, right? The diameter of a macrophage is roughly 10 micrometers. So these are readily phagocytosed by macrophages. And you can see here on the right-hand side of the screen how the surface looks before and after cleaning with this ultrasonic tip, where we really abrade all the portion, all the external portion of titanium. And please remember, that external portion of titanium that's called the passivation layer is what makes it so unique, so suitable for osseointegration. And what I feel here in the follow-up of that study, what I feel is really an amazing finding, is that when they got these particles coming out of the ultrasonic and they put it in the back of mice, they appreciated this is how the bone looks like, okay? In the back of a mouse, you can see the nice lamellar structure, and you can see the osteocytes in the lacrinae. This is just good skeletal bone. You can see what happened here. Wherever we have titanium particles, we have resorptive, we have osteoclastic lacrinae eating up the bone. So there you go. This is direct proof that these titanium particles alone, without LPS, without bacteria, they can cause destructive inflammation. And you can appreciate in the chart here that the effect that titanium had to inflammatory bone destruction was actually greater than what bacterial LPS had. So going back to peri-implantitis now, we need to rethink, why is the pattern of this defect so unique to implants and so different than what we know for teeth? For teeth, the vast majority of defects are horizontal bone loss across the board, what we used to call generalized severe chronic periodontitis. And now these peri-implant defects, they're saucer-like, they have kind of a moat around the implant. And what's even more impressive is that you can have multiple implants. And this is an implant that has expected bone loss for that platform matched implant type of about down to the first thread. And this is an implant that has lost over 50% of its bony support. And look at this. That moat is well contained and doesn't pass from one implant to the other one, despite that minuscule 4 millimeter distance. So if we were to have bacteria, it is very reasonable that bacteria would definitely infect adjacent sites. But if we have a local implant surface related causal factor, such as titanium particles, it just makes way more sense that we have kind of a circle around the implant where these titanium particles reach as they come, as they dissolve from that implant surface. And that's where the inflammatory distraction is contained. Just some food for thought. And another point that I want to make is I just want to remind you why the passivation layer is so important. Now, talking about some facts in terms of titanium surface and peri-implantitis, excuse me. Well, we can do it on this slide as well. So this is a case that I got from a failed study. I wasn't involved in this study, but what these people were trying to do, they were trying to do vertical bone regeneration around implants with peri-implantitis. And obviously, as you can tell from this image, that failed. But what happened is, on the right-hand side, we have one of these old implants that had peri-implantitis and were exposed in the oral fluids and bacteria for quite some time. And on the left-hand side, you see an implant that was just placed 6 months ago. And you can see how with time we lose that shiny metal appearance of that implant, that titanium passivation layer. And look at how the implant looks like after many years in function. You can appreciate literally the rust on the implant surface. And when you think about it from a material science perspective, as I told you before, the titanium passivation layer is what makes these implant surfaces bioinert. And that's why titanium implants and zirconia implants are so biocompatible. And by the way, I want to tell you, this is what we see here. If I'm able to do a scanning electron microscopy, really high magnification out of this small surface of that failed implant, I would be able to see all these granules, all this breakdown of the surface. See how it looks like pebbles. This has nothing to do with the pristine morphology of a sandblasted acid-etched surface. This is now a corroded surface. And if I may say so, zirconia implants are being touted as the metal-free implants. But while we won't have the time to get into that today, I want you to know that zirconia implants are clearly metal implants that are covered as well by a passivation layer. And in that case is the ceramic zirconia layer, right, of the zirconium dioxide. So any metal can corrode, and there's newer studies from Olmedo et al. Showing that these zirconium metals can actually leak zirconium particles. It just happens that this ceramic layer is just even more robust than the titanium layer, and this might happen just at a much, much slower rate. So there's definitely a lot of interest in zirconia implants for the future, and they might reduce the incidence of peri-implantitis, but clearly it's rather maybe not suitable to say that they're metal-free. So that's just a small parenthesis. But it's striking when you think about peri-implantitis as an issue of metal corrosion, as titanium corrosion. Look at the colors here, the discoloration, the brown and greenish hue. This is no different than the bike chain of that rusted bicycle. And now moving on really quickly to implants. I've talked extensively about the oxide. This is just a very nice high magnification image of how the oxide looks like. And you can see that between the organic bone, the mineralized organic bone here, and the implant surface, there's always this interface of titanium dioxide that bridges the two. And the role that it plays there is that it prevents further corrosion of the implant. It prevents the particles coming out. And what I'm very excited to share with you today is that we've actually recently found and published that titanium is an extremely robust metal. Titanium is being used in submarines. It's being used in pipes with constant flow of water, extremely robust to corrosion whenever we have atmospheric conditions. So whenever we have atmospheric conditions, even if you abrade it, it will likely repassivate promptly. But when we have anaerobic conditions in the 7mm pocket of peri-implantitis, then the corrosion resistance changed drastically. And you can see in this graph here that this is the corrosion resistance of aerated titanium dioxide. And this is what we published when we remove oxygen, when we replace that with nitrogen. Look at how manyfold lower that corrosion resistance is now. And in that vicinity of impedance, this is now becoming a metal that is prone to corrosion. And what you see in the schematic here is what actually happens if we abrade that metal implant in cases of anaerobic, acidic, inflammatory reactions. You can see, I hope you can see that quite well, but whatever is green is the titanium dioxide signal, and whatever is red is actually the titanium bulk metal exposed signal. And you can see how the green now is diminished, and we have just a ton of metal exposure throughout the surface. So this is just fascinating to me because it provides a direct link of how the two can come together. And now for the last part of the presentation, I'm going to show you how this can be translated into clinical practice, how we now treat cases. Mark, just to be able to stay on time, do we have about 10 minutes more, I believe?
Yeah, go ahead.
Yeah. All right. So this is how we treat cases now. First of all, what we do is that we remove the crown of the implants to be able to get tissue to cover that area, to be able to have primary closure over our implants. This is an old technique by Langer the spontaneous inside-gingival augmentation that we've translated to implants. So you'll see that whenever we can, we will remove the crowns. And then we access these defects, and we make sure that if any metal instrument is to be used, for instance, for removing granulation tissue, that metal instrument faces the bone and touches the bone, but not the implant surface. And back in the day, when we first started doing this proof of principle case series, the only thing that we used was cotton pellets. And these cotton pellets just had saline on them. So it's really a proof of principle. How much do I need? How much antibacterial activity do I need to be able to clean these surfaces? And this, once clean, these defects are just extremely hard to manage because, as I said before, we don't have the PDL, we have very limited blood supply, and the osteogenic potential is just very limited. So always intramural perforations happening, and using scaffolding materials that are not only osteoconductive but have also osteoinductive effects, because again, I'm missing my PDL-derived blood supply, the growth factor influx, and whatnot. So in this case, this is one of the earlier cases we used Infuse, which is a recombinant BMP2, just a very strong osteoinductive signal for osteoblast progenitors, the traditional hard swelling with Infuse happening. And you can appreciate how we get from this situation to this situation. And I apologize, this is a partial thickness flap because we have very limited keratinized tissue, but you can see the coronal tissue attachment around that implant that had the massive defect. And then fixing whatever else is part of the problem. For instance, in this case, the limited keratinized tissue with a T-shaped free gingival graft. And this is what happens post-op. This is the original defect level, and this is how much bone gain we have. And what is critical here is how did I get long-term? How much stability did I get long-term? This is 3 years later. And I know I didn't get all the bone all the way to the top, didn't cover all the threads, but it's impossible because I can't really grow bone vertically above the area of the bone where the adjacent implant is. But I've grown bone that looks to be in contact with the implant, and I have long-term stability over 3 years. I'm past this 1 year landmark of about 100% relapse and haven't used nothing but water. So this really implant-driven protocol is based on avoiding damage to titanium surfaces, reducing biofilm bacteria, reducing titanium, restoring titanium cytocompatibility, and achieving reosseointegration. And to close with this, I'm going to show you a clinical trial that we've started to exactly prove that point from an evidence perspective. So this is, again, our standard approach when we remove the crown. This is performed by Dr. Eddie Lee as part of his participation in our trial. You find a little chunk of cement here, which is always good news, as it's going to be discussed later because it's part of the etiology. And then look at what happens with inside of mucosal augmentation. After 3 weeks, you now have great quality keratinized tissue covering over that implant where we've placed a cover screw, of course, and giving you more opportunities to do primary closure, have more good quality tissue to work with. And clinically, once we open up the defects, we have a specific protocol where we're using a collagen membrane, we're using an osteostimulative bioactive glass-based material, and then we use locally harvested autogenous bone chips. And why we do that, why we use osteostimulator or osteoinductive biomaterials is, again, based on evidence. And what happens is, I told you before, we can't really remove the entire plaque biofilm from the surface. We can just reduce the microbial load. And what that does is that it makes the surface to be less conducive to bone cells. You can see here, this is an assay we did of chemotaxis, of how quickly can bone cell progenitors come towards the surface when it has been previously coated with a peri-implant biofilm. And you can see that they really they enjoy running towards an implant surface that is sterile, pristine, but they don't do well versus a surface that has a previously grown biofilm on it. And with the use of an osteostimulative calcium phosphosilicate based graft here, we provide a strong chemotactic signal to the bone cells, which is primarily slowly reduced calcium coming out from a glass silica matrix. And you can see how we can restore the chemotactic ability of these bone cells. And because I like visuals, this is just a very nice visual of how the bone cells, this kind of jello layer, these are all bone cells on an implant surface, and you see how they grow directly underneath these particles. This is just a very, very nice visual to appreciate why we need something more than just an osteoconductive biomaterial. So this is our protocol. We use a micro-os, which is a beautiful instrument. If you don't know it, it has kind of the thickness of an actual pen, and you can sneak it underneath the flap and get a very, very nice quality of particulate autogenous bone. And we mix it at about 30 to 70% with either osteostimulative or osteoinductive biomaterials. We place it in the defect, never too much, cover with a membrane, and go for primary closure. And this is how the case looked like. A diagnosis. Here you can see the micro-os harvesting the bone chips. And this is how the case looks like after treatment. We have shrinkage of the tissues. We have reduction of inflammation, and from a 9 millimeter, we're now to a healthy 3 millimeter per implant pocket. And I think I'm going to wrap things up here. We're about done with our time with a little video of how we're running our peri-implantitis clinical trial. This is performed by Dr. Arzuman at our UT Health San Antonio Grad Periodontics Clinic. And you see we're using a rotating nylon brush because we want to avoid, look at this difference here, we want to avoid these particles that are forming when we use the titanium brush, again, because they might be immunomodulatory per se. And you can appreciate how this is specifically designed to be able to fit either horizontal or vertically in the defects and clean the implant, and even get into intrabony defects that would be, I mean, a titanium curette wouldn't even fit there. And then after using the brush, we use our good old shoe shine approach. This is how we started cleaning implants, with just gauzes soaked in saline. Or you're going to see here in just a minute how after using the nylon brush to clean up the intrabony defects, yep, right there. We use a shoe shine approach. This is just a gauze soaked in saline, and we burnish the implant surface. It's not complicated to reduce microbial load around implants. What the problem is the damage you can do if you overdo it. And here, the last part that I will emphasize, because we're going to talk about it later with different speakers, is look at the extent of the crown margin here. Look at how it's going beyond the implant platform. And you can appreciate how that is part of why peri-implantitis occurred here in the first place. So we got to get rid of all risk factors. You can see after using burrs, not touching the implant, but just the crown, and then polishing the porcelain intraorally, how we can manage this. And here, adapting a membrane. Well, this is a template for a membrane that I highly recommend to be able to get good adaptation. This is our osteostimulative biomaterials placed in the defect, and then a membrane placed over it. And this is pretty much it. And the entire protocol is available in the forum, in the main forum page. Mark, I think, uploaded that today that we currently use. And with that, I just want to help all my collaborators at the University of Washington and now at UT Health San Antonio for all the work that we're doing. Keep connected on ResearchGate if you want to see all our publications, and we'll just have a great discussion in the Q&A in the end. Thank you so much.
That was a fantastic presentation. I could honestly sit and listen to this topic all day in terms of management and the techniques shown. So that was just truly an excellent presentation. So our next speaker, I had the chance to meet last year in Boston at the Myron Nevins Symposium. And at the same time, I think it was around the same time as the release of his Zero Bone Loss Concepts textbook. So it's my pleasure to introduce Tomas Linkevicius today into the forum and nicely translate into our prosthetic phase of our symposium. So it's a pleasure to have you here today.
Hello, hi. So let me start. Okay, so good evening, everybody, because it's evening in Lithuania already. I know it's just a nice day in Toronto, as I heard.
Nice and sunny.
Yeah, is it okay? Do you see the presentation? Fine.
Yeah.
Well, I want to talk about crestal bone loss after delivery of the restoration. What can we do about it? And emphasize not only prosthetical part, but also emphasize probably more also the prevention, how to, I mean, not to have this problem at all at the first place. Because what previous speakers have told us and what we see, of course, this is what we strive. And if the crestal bone stability, the implant has stable in the bone, so we are all out of our jobs. So no peri-implantitis, okay, no treatment, but I think that this is what we would like to have actually, despite this. I'm originally coming from Lithuania. Now I'm serving in 3 main positions. I'm a professor, Institute of Odontology. I'm running a private research center. Any studies which I show today were performed in private research center, not in university. It's kind of unique thing we have developed here in Vilnius. And I'm also a clinician, like all of us who are here, because at the end of the day, this is what we want to have. We want to make our clinical work better. For several, I think, for years, I'm usually starting my presentation about bone stability and peri-implantitis and the factors with these 2 X-rays. And this is the same implant. Actually, the brand of the implant is the same. They are restored in a similar fashion. However, and we see that this implant has the small 1.5 millimeter bone loss. And I'm sure a lot of people will say, okay, so is this important? You know, this primary bone loss, and maybe it's physiological, we should keep it like this. But I think this is all just excuses by not fully understanding why we have this bone loss. And I'm sure that everybody of us, if we would have a choice which implant we would have in our mouths, I think we would definitely go for this, although this is just a little bit of bone loss. Tomas Albrektsson was mentioned today by Rick, and rightly so. He was one of the giants of our profession. However, I would like to point a little bit earlier paper of Albrektsson, published in 1986, where he said that 1.5 millimeter bone loss is success after 1 year. In that sense, I think this paper, of course, at that time when it was published, you know, it's 40 years ago or almost, that was kind of different reality. But until now, people tend to refer this as a success. And usually when they have this initial bone loss, crestal bone loss, they consider it as a successful outcome, which I think it's not. Because what, let's say, our concept suggests and what we want to see and what we see is we have opposite, let's say, reaction of the bone. We have sometimes 1.5 millimeter growth of the bone with time if the implants are placed according to its design, and all, let's say, prevention, peri-implantitis prevention features which we have developed are put into the place. I'm sure that everybody is familiar with this X-rays in that sense, that all of us have had this. So these all are my X-rays. And here you can see this initial bone remodeling or initial bone loss. And that's why, I mean, it's so common. But I will refuse to say that this is success. I refuse to say that, you know, this is just a little bit, because even today when we talked about peri-implantitis, that I think even if the bone is does not resorb more, but still we have less stable situation, and with reinfection or in a change of patient immunology and all the things which we have discussed in the previous lectures, of course, implants with bone loss are more, let's say, susceptible to peri-implantitis. Here I'd like to discuss 3 scenarios, what can happen when we have this bone loss after restoration delivery. So one scenario is kind of positive one. When we restore the implant, we place the implant, we have this initial bone loss, and here now we see probably because of the polished neck, but bone loss does not continue or continues just a little bit, like you see it here, 2009 and 2017, after almost 8 years. Bone was really stable, but now here is a little bit moving a little bit further. Now, still, this is one scenario what can happen, that bone resorbs and then it stops. It doesn't continue. Another scenario can be a little bit different. And let me show you one of the cases from which we're using in our protocol. Here you can see the implant placed a little bit too deep according to its design. So I would say this is not correct position of the implant, because this is implant without platform switching and no conical connections. It means that it's not really stable, and if you place it deep in the bone, this is what will happen. Here you can see the provisional phase, provisional restoration, and of course now what you're gonna do, you know, the bone, we have loss of the bone, but sure, you're not going to, you know, treat peri-implantitis here, or you're not going to remove the implant. I mean, you are going to proceed with prosthetic treatment. This is what we're doing here. After the provisional restoration, you see nice shaping of peri-implant tissues, and screw-retained zirconia restoration is delivered to the implant. This is a case with nice remineralization when there was no really obvious cause for bone loss, no cement, but we had bone loss at the delivery because of poor position of the implant. This implant was placed too deep. But after everything is settled, after everything is done, if the conditions for the bone are created correct and stable, you can see that after 1 year, we see remineralization, after 2 years. And this is how it looks after 2018. You see that complete bone remineralization. Now, it's not the growth of the bone. I would not consider it a growth of the bone, because you have the bone defect and the bone just became more mineralized with time. But so this is delivery. This is 7 years follow-up. And, you know, it was a positive outcome for this implant. My point is that when you have initial bone loss like here, does not mean that the bone will proceed further. You can have stabilization, or you can have recurrence of the bone or remineralization. And indeed, you can notice here, you know, how actually the restoration has changed. This is how it looks. And you see after 7 years of work, clearly worn surfaces of porcelain, also porcelain around on tooth restoration, means that indeed this was functioning. And probably, and I would say, you know, we could argue about this, but I see loading usually as a positive effect on bone, as with this, it's let's say a micro stimulation than the negative. And maybe, you know, that was one of the reasons as well, besides all other factors which created this positive environment for bone remineralization. Let's discuss scenario number 3, which can happen also. So you have, let's say you have bone loss after delivery or restoration. There is already a third way what can happen next. I call this like implant placement with closed eyes because the situation is so good. You see, the bone is wide, you have attached tissues. We selected an implant with platinum switching and conical connection. We see nice healing of peri-implant tissues, delivery of the restoration, and after some years, after 1 year, you can see a little bit maturation of the tissues. But of course, here, X-rays, you know, it's important because when we talk about bone stability, you know, you cannot, or peri-implantitis, you cannot do without X-rays. So here they are, placement of the implant according to the design at the level of the bone, initial bone remodeling already at the 2 months. And this is not 10 years follow-up. Yeah, this is just delivery X-ray where you can clearly see no bone loss. And that is a real problem because in this particular case, bone do not go back, remineralized bone did not stop, it just bone loss continued. And this is what we have. After 1 year, you see the half of the implant is out of the bone now. Naturally, the question comes then, which factor is most important for this? What causes and why in these different kind of situations you have 3 different kind of outcomes? Because as we, of course, already agreed and we understand, that is the scenario we want to avoid. Starts from initial bone remodeling, goes something like success criteria by Albrektsson, but bone does not stop, continues, and here you have actually peri-implantitis after 1 year follow-up, and you need to remove this implant in order to graft, and maybe we have a possibility to place another implant again. This gives me the understanding of difficulty of the procedures. And if we would look at just, I mean, a recent publication from evidence-based dentistry, conclusion says that there is no, of course, reliable peri-implantitis treatment. It's unpredictable. It's like flipping of the coin. And we all know that that's until, you know, you can have different kind of treatments, but no, it's still not possible to make sure that you're going to treat this. This gives me the understanding that the best treatment is prevention. And here what we need to put in, what protocols we need to do in order to have prevention of initial bone loss, which later can lead to peri-implantitis from surgical part and also from prosthetic part. And then if we manage all of this, then I think we will have great reduction of this problem. That's where zero bone loss concepts come in, and the book, which was published almost a year ago. Now we also have this online education and normal courses, which of course now are restricted. But that was the point how I thought what we need to look at. You start to solve the problem, you see the problem, and now how we're gonna solve this and what factors you need to look at in order to stop this just at the start, not to go further. Before we go a little bit more into the factors, I just want to share what again can happen with the implants from a positive point of view. And now we're talking peri-implantitis, but here is the clinical case from our study, which we published in 2013. That was study with vertical augmentation of the tissues, of the soft tissues. And you can see that after 6 years, you see a clear vertical growth of the bone. Now, this is really growth of the bone because there was no defect at the beginning, at the time of implant placement and delivery. So this is delivery X-ray. This is after 6 years. You clearly see that the bone is growing. Now, I don't know exactly why it happened, but I know what we did with this patient, what procedures which we took, and that, of course, might influence the outcome. In other words, changing tissue biotype, making it thicker in vertical direction, somehow creates a positive environment for the bone. And if all other metabolic or immunological factors are okay, we can have bone stability. As well, not only the bone, we see with our cases the growth of soft tissues as well, or changing soft tissues in a better condition. This is again the case from one of the clinical studies which we're running, and delivery photo, this is zirconia crown. You see obvious like defect. This is how it looks after 1 year. It's no grafting, there was no grafting done, but apparently this is prosthetic part, what you should apply in order to gain soft tissue, better soft tissues. Well, what are those factors, in my opinion, which we need to look at and which we need to take care? Of course, there are a lot of them, and I just will distinguish few, the most important, in my opinion, ones. We have to structure it into 2 big groups: implant design factors and biological factors. Let's start with implant design, and I'm sure that I'm not going to say something new here. All this information is available, was available for many years. A polished neck and microgap, or connection between implant and abutment. For implant design, I think those factors really matter. And polished neck is if the implant has polished neck and it's placed too deep, like you see here on this short implant. You have initial bone loss, which will stop just at the rough surface of the implant. However, not always. As I was already saying, you see that the bone loss continues and you have lost the implant. And here, it's a very nice case because we have another kind of implants placed side by side. Actually, it is the same patient, and it's all really integrated and connected. And those implants did not have polished neck, but all of them were placed actually at the same level. So that's why I'm advocate of not placing polished surfaces below the bone, because I know people say it's controlled remodeling. Here you go. This is your example of controlled remodeling. Sometimes controlled remodeling becomes uncontrollable and you are losing the implant just because you started it in the beginning with the wrong position of the implant. That's why we have lost it. Microgap point of view, we should look from 2 sides, from bacteria side and from the connection stability side, because we all know again, and this is the case I showed before, and as an example of poor position of the implant without lateral switching and conical connection, too deep actually, and you see this is what you see after just delivery. Of course, we know the story further, bone remineralized, but that, of course, does not always happen. Here, it's also important connection, how stable it is, because on that, especially with suppressively placed implants, is important. The deeper implant goes, the more conical connection stability it should have. And from pure, let's say, implant design point of view, you know, the smaller the number, the better the connection. But I always say that, you know, implant design should be put in context. I mean, if you have implant with tapered, with more tapered connection, it doesn't mean anything. You know, it's just a feature of design. It means something if we put that thing into the bone, in the context, and context is biology. When you're putting this into, then you can really see the benefits of the connection, but it doesn't mean that you can achieve that only with that type of connection. But if we would look again just from the mechanical point of view, from implant design point of view, this probably would be the best design implant. It has no polished surface, it has platinum switching, it has long conical connection of 5 degrees, actually probably no movement. And if you have here bacteria inside, the bacteria would not be going out because of the connection. But is it true that always, you know, if the implant design factor is like that, do we always have bone stability? Of course not. Just one of the examples, implants placed in the upper jaw, nice healing. You see the keratinized tissues around implants, and so biological factors from that point of view are okay. But for some reason, you see here that you have bone loss before the loading, and again, this is just a delivery of restoration and not 10 years follow-up. And this is happening around implants with, let's say, good design with connection stability, no platform, no polished neck. Question why? Answer is here, because as I said, we are working in the context, and context is biology. So you cannot just say isolately, you know, the steeper the connection, the better the stability. Doesn't matter. I mean, I can show you thousands of X-rays with, let's say, tissue level implants, which connection is not that stable. But when the connection is isolated above the bone, then it can be less of stability, and you can still have bone stability even with less connection stability. So I think we should, you know, put this, that you need to combine these two things in order to then say which implant design is superior. Now, what biological factors we need to know and we need to take care of? Of course, we have attached tissues, keratinized tissues. I would say even maybe immobile tissues, because I'm not sure that we always did keratinization. In my opinion, this part should not be mobile. And if it's not mobile, means then you can really have this adhesion of the tissues to the surface of abutment. So that's the purpose of having attached tissues, that they would not move. I don't think we really need keratinization over there. Horizontal thickness, sure, biotype. But what we have been really missing for many years is vertical soft tissue thickness. And we've been not discussing it for many years, because maybe this is the part which can explain this bone loss and this 1.5 millimeter bone loss, which we consider as a norm, as a physiological, which I think does not exist, physiological bone loss. To better understand, I put everything into one slide that we would know what we talk about. Vertical tissue thickness is measured at the crest of the bone. Yeah? So you have here, horizontal tissues are measured here, and attached or keratinized tissues are measured a little bit lower. It is easy to confuse both of these two, because both of them have vertical component. However, they are different, and they have different kind of function, because this is important after implant restoration, and this is important before implant placement as well. Now, why then we need this vertical tissue thickness? Because from that portion of the tissues, we have formation of biological width, not from attached tissues, not from keratinized tissues, from verticals of tissue thickness. And biological width, of course, is our protective measure. And here you can see a nice video, when you remove the implant with tissues which were glued to the surface of the abutment, what you can see, it's a clear difference in cleanness. It means that if you have thicker tissues, you have the possibility to develop more clean zone, as you can see it here. Yeah, this is plaque zone and this is clean zone. So if the clean zone becomes higher, it means you have a better protection. If plaque zone goes down, here you go, you have your peri-implantitis. So bacteria is really coming closer to the bone. That's why biological width is important, and that's why vertical tissues which form biological width are important. Here you have usually two different scenarios with the patients. You can have thin tissues and you can have thick tissues. Maybe, this is implant would behave differently. And this idea of vertical tissue measurement is not, let's say, idea of our group. What we did, we just really expanded a little bit more clinically, but the original suggestion or original idea was from Berglund and Linde in 1996. They published a paper when they had dogs with thick tissues, about 4 millimeters. They thinned the tissues to 2 millimeters, and then they watched that after the healing, with this thin tissues, they had additional 1.3 millimeter bone loss. And they concluded, if you have thin tissues, you're gonna have bone loss. And what we did, we actually repeated the study clinically, because of course, you cannot just take an animal study, and say, look, this is now, we should do it clinically. Because that's really a big problem. By taking animal study into animals data into clinical reality without checking them clinically. Of course, maybe some of the studies you cannot do clinically, but we should not blindly just say something like regeneration works in dogs. It doesn't mean that it will work in human beings, because dogs represent the best outcome, because they heal much, much better and much, much faster than human beings. And for example, we have formation of the bone in dogs. By applying certain, let's say, bone substitute doesn't mean that it will happen clinically, because, as I said, that's why clinical studies are important. And here what we did with that study, we placed implants, so they were test implants. We placed them supracrestally in order to isolate the polished neck and the connection and microgap. And then we measured tissue thickness over these implants. Then we were able to really test how tissue thickness influences bone stability around this implant. And we found that in tissues in group A with thin tissues, we had really almost identical number with Berglund and Linde, 1.35 millimeters of bone loss after 1 year, while in thick tissues, we had only 0.25 millimeters of bone loss. Now, this was published 2009, already 11 years ago. It's not a new study, it's already, an old study, but still it's clinicians, I think, tend to devaluate the importance of vertical tissue thickness. I think if you are not measuring it, you cannot be successful with peri-implantitis prevention. If tissues are not measured, I consider it the same. Let's say you are not measuring the width of the bone before implant placement. Sure, technically you can place implant, yeah, but you will have problems, yeah. And clinicians find that, maybe bizarre if you would not measure. But with tissues, it's a different factor that always should be measured. What I like about clinical studies is that I can follow up these patients, not of course all of them. We all know the dropout of patients, but in this case, I had a chance to see the patient after 12 years, to see the placement from the thick tissue biotype, placement supracrestal implant, 1 year follow-up, 12 years follow-up. And again, what we're seeing actually the growth of the bone. And I'm sure that thick tissues really contributed to this factor that for a positive, good environment for bone to behave like this. What about platform switching? What about platform switching and tissue thickness? How do these things work? Because at that time when we were developing the idea of tissue thickness, a platform switching was considered to be the best design, and a lot of studies, systematic reviews, clinical reviews stated that implants with platform switching do better preserve crestal bone stability than implants with matching abutments. We kind of already had at that time the data, and I found that actually none of the studies which were talking about platform switching were really measuring tissue thickness. What we did when we made this pilot study, as you can see it here, we gathered the patients with thin tissues, 2 millimeters or less, and we placed 2 implants side by side, implant with platform switching and without platform switching, at the level of the bone, and then we restored the implants with splinted restorations. This is what we found, that placement of the implant, 2 months of the healing, we already see bone remodeling because implant is exposed and the tissues are thin, so the bone starts to resorb, and this is how it looks after 1 year follow-up. In other words, there was no difference between implant with platform switching and implant without platform switching. This again brings the understanding of implant design importance. We know that platform switching conical connections are most superior implants in design, but if you put those into the context, in the biology is unfavorable like here, it doesn't matter. There is no superiority of implant design if the tissues are thin. But that's the important message I want to tell you. And here we can explain this really easily. This is implant without platform switching, regular connection, has no bone loss, placed according to the design. Yeah, but look at the tissues, and this is implant with platform switching. Again, placed according to design at the level of the bone. Better conical connection, everything is better, but the tissues are worse. That's why you have stability, and here you have this bone loss, which could have been easily avoided. Take-home message from this part would be that what is the minimum thickness of the tissues? In the studies, we were used 2 millimeters. However, now we did additional studies, and I'm sure that the minimal amount should be 3 millimeters vertically, and optimal even 4 millimeters, because then you already have the space for emergence profile creation, and that influences your crestal stability as well. To put it, of course, together, because as I said, zero bone loss concepts is a combination of both surgery and prosthetics. That's the only way to discuss actually peri-implantitis, because you cannot just divide those into, is it surgery or is it prosthetics? Because it's both factors are important here. And one of the most, let's say, important decisions we need to make is to do cementless curetane restoration. And let me show you one of the clinical cases where I think explains how we should look at this problem of restorative factors for crestal bone stability. For a long time, I was showing this as a success. You can see this images is at 10 years old. Yeah, this case is 10 years old. And we had a successful positioning of the implant. I had to make a provisional restoration where I shaped, sculptured the tissues very nicely. Position of the implant is good. And as I said, many years I was showing this as a good example. Now, at that time, there was no zirconia abutments. We had to do a gold cast abutments. Now we know that it's not good, of course, but 10 years ago, it was different reality. And patient for many years was successful. And in 2018, the patient came back for follow-up, and still we can see that the margin is okay. Yeah, there is no recession. Well, you can see maybe a little bit, not 100% fill of papilla, but it's almost 10 years, and we all know what's happening with the implants. They become in infra-occlusion. Here you have everything is nice. However, when we looked at the X-rays at 2018, we found peri-implantitis. 2009, okay. 2013, everything's fine. 2018, suddenly we have a huge bone loss, angular defect. What do we do in those cases? Of course, first of all, what you do, you really remove the restoration to see what's inside. I think it's not possible to treat peri-implantitis in any situation without removal of the restoration, because that then gives you the access. That's one thing. Another thing, they might be a situation like here, because what you are seeing in this video is the semen remnants which were in the tissues for 9 years without any symptom. Suddenly, at the 10th year of function, we have peri-implantitis. And also look at the surface of abutment, how rough it is. Remember, the golden abutment was smooth before placement. That's actually why gold should not be used as a subgingival material, because with time it becomes rough. That's not biocompatible. Cement and the roughness, I think those were factors which caused this peri-implantitis after prosthetic delivery. If you would think that this was an old truth with everybody knows, you would be wrong, because only in 2013 American Academy of Parodontology has recognized cement as predisposing factor for peri-implantitis disease development. Only 7 years we had it. Like 10 years ago, this case would not be explained because semen remnant was not considered as a factor for late peri-implantitis development, meaning that in just case like you saw it here, everything functions very well. Suddenly, after some time, you see bone loss, and residual cement might be a reason for this. When we had this case, I always had this question, so why it stayed, why it was asymptomatic for so many years, and suddenly it became symptomatic and the bone started resorb after 8 years of function. To explain this, we have developed an algorithm. I think the important, of course, in the beginning is the distance to the bone of the semen remnants. So if the semen remnants, for some reason, come close to the bone, you have this acute quick peri-implantitis, which we have witnessed before. So everything goes swiftly, bone resorbs, and you end up with bone loss. But usually it doesn't happen. Usually implant sits somewhere in the sulcus, somewhere like here, when you cannot clean it, but it's still far away from the bone. And here, in my opinion, it's very interesting that you have combination of two different factors for peri-implantitis, because history of periodontitis is by itself a factor. And here, if the patient has history of periodontitis, then there is much more chance that you will have development of peri-implantitis with a cement. Because when we look at periodontitis, we'll know that, what is the relation between periodontitis and natural calculus. And it's very similar that we can call actually cement as artificial calculus, and it actually irritates the tissues and harbors infection. The description of relation between calculus and periodontitis and semen remnants and peri-implantitis sounds like this, that no, there is no etiological association with periodontal disease process in case of calculus, but it acts like a predisposing factor due to additional retention for bacteria and mechanical irritation. So here you have, and if the patient is periodontally involved patient or has history of periodontitis, it means that this becomes faster, this connection. And if the patient has no, and for example, young patient, so that takes a lot of time. That's why can we explain this patient, the case I showed before, because that was a young patient. The implant was placed in 25, when patient was 25 years old. So usually they are not periodontal involved patients, and that's why it took 10 years for this cement to do its bad work and to cause peri-implantitis. From complication point of view, from cement, these are two different patients. In this patient, we could say that semen remnants, if there are, they would not really be very quickly exposed, while in this patient, with this perio patient, this would be faster. Let's return now to the same patient, and let me finish this story because it's not finished yet. In the lower jaw for the same patient, we put an implant and restore it with screw-retained restoration. And this is how this implant looks after 10 years. Placement, 1 year follow-up, and 10 years follow-up. No bone loss, and here you have a lot of bone loss, peri-implantitis, because you just selected cemented restoration. And I would say that actually this is the choice for prevention of peri-implantitis from prosthetic point of view. Choice between cemented and screw-retained, I think this is most important. And if it's screw-retained, you have less problems, less chance to develop peri-implantitis. Now let me finish up this case with a good outcome. And again, it really confirms what we have talked about, that the patient, remember the same patient, 2018, what we did, we cleaned the cement from the restoration and I put the same restoration back, and look what's happening. After 1 year, we are already seeing remineralization of the bone. So we just removed the cause, removed the cement, and that gave us a better outcome. Rosling et al. In 1976 have confirmed this, that when you remove calculus from teeth, you're gonna to have regrowth of the attachment. And the same is around implants. If you see the cement, remove the cement, and that would be the first treatment. Don't rush into raising the flaps, and grafting. Let little bit nature do its job. Let me finish up with some take-home messages. From my perspective, from perspective of zero bone loss concepts, vertical soft tissue thickness is a separate measurement. We should measure them, this thickness, before implant placement. And if you are not doing this, then you are missing one of the most important factors for bone stability, and you are not really using everything to stop peri-implantitis. 3, 4, 5, the thickness of the tissues, so 3 millimeters minimum for optimum, 5 maximum. Of course, crestal bone stability is multifactorial, and as a peri-implantitis is a multifactorial disease, from prosthetic point of view, I would say that screw-retained would be one of the most important things we should apply to our patients. With this, let me thank you for your kind attention and looking forward to the discussion part at the end of the lectures. Thank you.
That's fantastic. So for those who have not read the Zero Bone Loss Concept textbook, and now, as you've mentioned, it's also available online. I'd recommend to check it out to pursue further into this avenue of implant treatment. So we have our next speaker, and I'll let Sanjana introduce him. A dear friend with an amazing concept who I've been implementing the last 2 years in practice. So I'll let her introduce him.
Looking forward to our next speaker, Ioannis Vergoullis. Like many other big people, he graduated in a 10, and he made my job easy because he has also done periodontist training in the States, like Kotsakis, so I didn't have to remember. And but he has also done a master in oral biology. He has 13 patents. Wow, Ioannis. And he became worldwide famous with VPI cervical. Ioannis, let me hear you.
Thank you for your nice words. Mark, thank you for the invitation. It's great to be here among such great speakers. And I watched all the presentations very carefully, and they gave me a lot of things to think about over the next few days. So this webinar is about stability. And the main issue that we are dealing with is how, when we start practicing for a long period of time, how can we minimize the cases that we have presenting bone loss and failure, and how can we increase the amount of cases that they present stability? And if we look into the failures, we will see that the number one enemy is peri-implantitis. So most of the cases that they are going down the road, this is attributed to peri-implantitis. And the problem with peri-implantitis is that it shows to have a very high prevalence. When systematic review and meta-analysis shows us that about 18.8% of our patients can develop peri-implantitis within 5 years, this is really dramatic. And that makes you wonder what happens in the real world and not in university environments. And in the real world, we see from the literature again that these cases might range anywhere from 5 to 53%. So these are very big numbers. And the problem with peri-implantitis is, like George mentioned in his lecture, that it's an aggressive type of infection. So it can start very fast and it can progress very fast, unlike what we see with periodontitis. And it has to do with the morphology of the disease and how it invades into the soft tissue and into the bone. It actually invades on the bone. So it is very clear to me that it's very important to achieve prevention. Like Tomas said, I think that the best treatment for peri-implantitis is prevention. It's any type of treatment that we know so far, it seems to be unpredictable. Hopefully this will change with the work of George. So when we look into prevention, we have two factors that we need to consider. And this is the host response and the treatment protocols. And when it comes to host response, we know that there are certain medical conditions and certain medications that have been associated with less favorable response towards implant therapy. When we go to treatment protocols, it is very important to understand that both surgical and restorative states of treatment can have a very significant effect on the development of peri-implantitis or on the prevention of peri-implantitis. And Tomas again mentioned about cement sepsis, which is one of the main factors that can lead to peri-implantitis. Now, what I want to focus in this presentation is this little area of soft tissue above the implant platform and how this interacts with this part of the prosthesis that is installed in this area. And this is something that we called implant transmucosal complex, and we are trying to describe this and hopefully publish it because we have been looking only into the soft tissue, but in reality, we have a reaction between both the soft tissue and the prosthesis. And when we look at this transmucosal complex, descriptively, we can say that it has a margin, which is called the cervical profile. And this is the free margin of the gingiva that will accommodate the cervical margin of the prosthesis. And then we have the area that extends from this margin all the way to the implant platform. And this is the submergence profile of the prosthesis, or the emergence profile of the gingiva. And we need to understand that how these two interact, the soft tissue and the prosthesis in this zone, it's biologically important. And why is that? Well, we have to start by looking at the soft tissue. And we know from 1999 that the soft tissue forms a seal, forms a barrier that acts as a protective barrier against the bacteria present in the plaque zone. So what is in reality the peri-implant seal? Well, the peri-implant seal is the area of the connective tissue adhesion and the junctional epithelium zone. These two zones seal the area on top of the peri-implant bone and act as a barrier, as I said, against the bacteria present in the sulcus. And how can we build this? Well, it's pretty straightforward. The body does that for us as long as we provide enough soft tissue height. And Tomas mentioned the importance of soft tissue height. And we know that from human histology, that the junctional epithelium and the connective tissue zones in humans needs approximately 3 to 4 millimeters. Of course, all these numbers are averages, so we have a variety from one patient to the next. But we need to provide the minimum that nature needs in order to establish this peri-implant seal on the abutment level and not on the implant level. So when we're looking into establishing a submergence profile or emergence profile, however you want to call it, we are looking at numbers anywhere between 3.5 and 5 millimeters. Tomas before mentioned the 3, 4, 5 millimeter rule. I personally, in my clinic, go for the 4 millimeters, and this is based on the initial studies from Vergoullis, where they showed that when they had 4 millimeters of soft tissue above the implant platform, in dogs at least, the peri-implant seal was able to be formed properly and protect the bone. So it is important, though, to understand that we need to plan for this feature when we place our implants. So sometimes we open the crest, we open our flap, and we see that we have a lot of soft tissue above the crest. This actual measurement of the soft tissue should not mislead us as far as where the implant platform must be located. So we need to understand where will be the zenith point of the prosthesis, and then establish a 4 millimeter distance from this zenith point to the final position of the platform. The second thing that we need, apart from soft tissue height, is biocompatibility. These zones of connective tissue and junctional epithelium require a biocompatible material in order to be properly formed. So this material could be titanium, or it could be a combination of titanium and zirconia, or zirconia alone, since we know that these two materials are biocompatible. But under no circumstances should be porcelain or gold. We know from Albrektsson study that if we extend porcelain or gold all the way to the implant platform, then what will happen is the bone will recede in order for the peri-implant seal to be formed on the implant surface and not on the suprastructure. So this way this implant starts its life in the patient's mouth, presenting bone loss and a deep pocket. So it becomes immediately susceptible to develop at some point peri-implantitis. Another question is if there is any way that we can make this seal stronger. How can we make it stronger so it can withstand better the time? Well, like everything else in our body, blood supply is very important. So we need to improve the blood supply. And how can we do that? This is by providing adequate soft tissue and hard tissue width. Why width is also important? We need to, when we look into histology, either animal or human histology, we will see that this area that is located around the implant platform lacks blood supply. The connective tissue in this area, it's a scar zone, it doesn't have a lot of blood vessels, and the gingiva, they receive their vascular supply only from the supraperiostal vascular complex. we don't have the PDL vascular complex anymore. All this blood from the gingiva, from the periosteal complex, comes from the lateral surface of the connective tissue. So by increasing the soft tissue width, we provide foundation to have better blood supply. And blood supply is very important because this is where the immune cells will come from, travel through the junctional epithelium into the sulcus and fight the bacteria present in the area. So how can we do that? We have two ways to improve the thickness of the tissue there. First of all, we can improve it by adding some connective tissue graft or by manipulating the tissue with a roll flap or M-IVAN like Snesiana has published. Anyway, with surgical techniques. The second thing is by providing proper prosthetic parts. An implant with a platform switch with a concave abutment provides more space for the soft tissue in the area. So we minimize the space that the materials will occupy in this area, and this way indirectly we improve the thickness of the tissue and the blood supply. Now, once with this peri-implant seal is established and is strong, now my question is, how can I maintain this on the long run? How can I make sure that this seal will stay there 5 years later, 10 years later? Well, we need to look into two things. The first one is not to disrupt it. We need to understand that this junctional epithelium zone and even the connective tissue zone, they are very fragile when it comes to implants. So mechanically, they can be easily disrupted. We can avoid multiple connections, disconnections of the prosthetic components by utilizing, for instance, intermediate abutments, or by improving our restorative protocols so we can move without multiple connections and disconnections to the final restoration. So this is the first way we can do that. But the second, and for me, the most important thing is to disturb the plaque constantly, and this is the job of the patient. So like everything else, oral hygiene is very important. The patient needs to be taught on how to apply proper oral hygiene and needs to be constantly motivated. However, this is only one side of the coin. We as dentists, we need to provide accessibility to the patient. So we need to make this area, this plaque zone, accessible to the patient so that the oral hygiene can be easily applied. And this is by conditioning the soft tissue. So, and in particular, the cervical profile. The cervical profile of the gingiva needs to match the ones of the prosthesis. Otherwise, this plaque zone that is located in this cervical margin area initially will not be easily accessible. So when we just don't condition the soft tissue and we provide a prosthesis with a mushroom shape that creates large areas of undercuts, these areas are very difficult to be accessed by the patient. And this way, the plaque remains undisturbed, shifts from a reversible to an irreversible stage and a mature stage. And then we have the development of mucositis and subsequently, at some point, peri-implantitis. And these two studies are very interesting. They basically showed, Monnier showed that 77% and Serino showed 74% of the cases presenting with peri-implantitis, they had a prosthesis design that did not allow proper plaque control access. So this comes to show that although in our mind peri-implantitis is a surgical disease, in reality it seems that the prosthetic part of the implant is probably more important than the surgical part. So under no circumstances, we should not be installing on our patients prosthesis with overhangs and areas that they are impossible to be cleaned, because the loss of these cases is out of question. So it's very important to provide soft tissue conditioning. The bigger the crown becomes, that means that it's not about aesthetics, it's about biology, it's about plaque control. So taking care of the soft tissue on molar sites is way more important than anterior cases. And the question is, how can I provide that? How can I do that for every case that I have, not only for anterior cases, but for posterior cases, et cetera, et cetera. So we know that there are certain techniques that we can utilize, like the cervical contouring technique from Nitzan, the dynamic compression, immediate temporarization or anatomical healing abutments? Well, because I don't have a lot of time, I will just go straight forward to the solution that I'm utilizing, which is the anatomical healing abutments. And I use this because I can do it in every case. It doesn't require extra appointments, and it's very straightforward and easy to apply. And we have histologic studies that they show that anatomical healing abutments are superior to stock healing abutments with regards to soft tissue thickness, gingival fiber orientation, plaque accumulation, etc. And this is what we also see in my clinic. When we compare the shape that we get from an anatomical healing abutment to a stock healing abutment, we see that we basically prosthetically enhance the soft tissue quantity. And I'm happy to see that Tomas before showed that proper prosthesis through different mechanisms, I guess, can also enhance the quality of this soft tissue. So basically, it seems that the prosthetic part of treatment can really help and go side by side with the surgical part of treatment. For me, as a clinician that basically is working in private practice 90% of my time, what it is important is that by utilizing these anatomical healing abutments, not only I get superior aesthetic results, but I can also get a more happy patient. And Beretta showed that when you condition the tissue and then you provide the prosthesis, the pain scores for these patients were way lower than in cases where they had to squeeze an anatomical prosthesis in a small cylindrical transmucosal zone. And at the end of the day, it's very important to keep our patients happy. So back then, when I came to realize that it is important to utilize anatomical healing abutments, I looked into the market and I saw what was available. And to be honest with you, I'm not going to get again in details, but I felt that there was nothing there that I could use. And I needed a tool that I could use to make my own healing abutments. And this is when I basically joined forces with my friend and partner, George Babs, who is a certified dental technician. So George could see the problem from the prosthetic and the lab point of view. I will see it from the biologic and the surgical point of view. And we joined our forces in an effort to make a tool that can help you create an ideal healing abutment. So basically, Cervico, it's a system of two tools, a guide and a mold. The guide helps me identify what kind of healing abutment I need. And then with the use of the mold, my assistant fabricates this healing abutment, I install it on the implant, and I go straight forward from surgery. Either this is 1 stage or 2 stages, to final soft tissue shaping and conditioning, so that now the restorative stage can move forward. And a very important feature of Cervico is that it's a tool that allows you to fabricate also the duplicate impression post. What we create in the mouth, it's very important to be transferred to the lab. Otherwise, the lab doesn't have the right information in order to design the proper prosthesis. And like we said before, the transmucosal complex is about prosthesis and soft tissue, how these two interact. So all this information must be transferred to the lab in a predictable manner. And the best way to increase predictability is by utilizing a customized impression post. And with Cervico, you can fabricate healing abutments for anterior cases, premolars and molars. Like I said, it has to be my routine in my clinic. I'm dealing with all the cases the same way. So I can go from a flat soft tissue architecture to this kind of shaping, soft tissue conditioning, and I can transfer this to the lab. Either this is an anterior case, or this is a premolar case, or this is a molar case. It doesn't make any difference. It doesn't require any extra skills. And when you get accommodated with the system, you see that you can utilize it in order to fabricate also anatomical temporary abutments and anatomical temporary prosthesis. And if you make this anatomical temporary prosthesis, you can easily duplicate them in the system, create a duplicate impression post that, again, you can utilize in order to get a predictable final impression. The Cervico system fully controls the cervical profile, and this is why it was called Cervico, which actually was a recommendation and idea of Nichan. As far as the emergence profile, the cervical system basically allows you, by default, gives you an S-shape of profile. And because it comes with two different silicone inserts, it allows you to make centric and eccentric healing abutments, which are useful for cases where the implant is placed at the center of the crest or more lingually, like in immediate cases. When we were designing the system, one of the parameters that we evaluated was the prosthesis emergence angle, because we have literature that is associating this emergence angle with peri-implantitis. However, looking into the literature, we found more research, and actually now we have very recent research that shows that basically the height of the shoulder of the abutment is what is very important, along with the shape of the shoulder of the abutment. So basically, if the shoulder of the abutment has enough adequate height and it has a concave or straight profile, cylindrical profile, then the emergence angle of the prosthesis is not playing a role in the development of peri-implantitis. So how did we accommodate for that into the system? Basically, what we did is we allowed the system, for the system to incorporate the implant replicas in different depths within its base. So basically, the implant analog, the implant replica can be inserted at 0 or -1 or -2 or -3 millimeters sunk inside the base. And this is what is basically doing is replicating the surgical protocol that the different doctors use for crestal placement or subcrestal placement with 1, 2, or 3 millimeters deep into the bone. And this way, the same kit allows you to fabricate healing abutments where the cervical profile is the same, but the shoulder height is different. So this way, you can have your cervical profile being developed anywhere from 3 to 6 millimeters from your implant platform. And if you create eccentric healing abutments, this distance becomes anywhere from 4 to 7 millimeters. And this is a feature that for me, it was very important. Anything that is prefabricated and available out in the market, I will have to accommodate my surgical placement for this part to be able to fit onto my implant. Meaning, if I place my implant a little bit deeper, then I will have to remove bone in order for this to fit. The cervical system accommodates the needs of the surgeon, of the clinician. So it adjusts to your needs. And the final question is biocompatibility. Will this healing abutment that I can fabricate with cervical be biocompatible? Well, if we look at it, by utilizing the shoulder of the proper abutment shoulder height, we have a titanium surface, and then we have the body of the healing abutment, which is composite, made out of composite. As far as the titanium portion of the healing abutment, this will accommodate the connective tissue adhesion. As far as the composite portion of the cervical healing abutment, this will successfully accommodate the junctional epithelium attachment. And we have plenty of research that shows that the composite, if it's clean, it can basically allow the hemidesmosomal attachment to be formed. Now, clean or rough, the junctional epithelium will be attached on the composite. However, we recommend proper polishing, because the more polished is the surface, it seems in vitro studies show that this polished surface can accommodate better the junctional epithelium, the better spread of the epithelial cells. And the second factor that we have to consider is that part of this healing abutment is into the plaque zone. So we need to have a very well polished surface that is not going to be amenable to plaque adhesion. One of the great advantages of having a healing abutment that is made out of composite, its custom body is made out of composite, is that you can easily modify church side and accommodate situations where the implant is not placed ideally. And moving forward to clinical examples, I will show you a very straightforward case. This is a flat soft tissue architecture, as you can see here. So I have to create everything from zero. I utilize the guide of the system in order to center my osteotomy. So I go and I drill through this guide, mark the entry point of my osteotomy, and then I utilize the rest of the tools of the guide, which is the surgical pin and the tabs, and I install the pin and the tab on top of it. I go ahead and I place my implant, and then I install immediately my cervical healing abutment. As you can see, during surgery, I have two parts that they are similar. They represent each other. So during surgery, I can see how my healing abutment will look like, and my assistant has the healing abutment ready for me, and I immediately install it on the implant. If I do one stage, like in this case, I immediately torque the healing abutment to the implant in order to achieve cold welding effect. I want immediately to introduce stability, macro stability between the two compartments, and I want the patient to be able to apply proper oral hygiene, again, very soon after surgery, because I don't want to allow any room for the plaque formation and migration into deeper areas in the transmucosal zone. We seal the hole with a Teflon, the screw access hole with a Teflon tape, and then with some composite material, the same way we will do for a temporary prosthesis. And this is the result we get 4 months later. So 4 months later, the soft tissue is already conditioned, so the patient can move forward with the impression stage. Now we have the duplicate impression post from the same that we fabricated from the same well of the mold of the system. And we utilize the one functional position technique. And you can email me, and I will be happy to send you the paper. And this technique allows me to have a very good stability of the impression post into the impression. And you can see now that by utilizing a customized impression process, whatever I have in the mouth, my lab technician has it available on the working cast. And then she starts the design of the prosthesis, where I always, and the restorative dentists were always involved in this process. In case you fabricate, in case you want to deliver a cemented restoration, then I will highly recommend you to follow this kind of protocols. You can see that whatever goes under the gingiva receives very good polishing, and Tomas actually has published on the importance of proper polishing of these surfaces. And like I said, if you have to go for cemented restoration, then I highly recommend that you utilize this type of custom final abutments, so that the cementation line is located coronally and laterally, so it's more easy to control the cement escape. However, since the angulation was proper, there is no need to provide a cemented restoration. The lab technician makes this a screw cemented restoration. So she basically cements the two parts extraorally with a permanent cement. And my restorative dentist, Marietta, is delivering as one piece the whole superstructure onto the implant. The second example is when we have an extraction. So Mother Nature already gave us the soft tissue ready. The profile is there. So basically, we take the tooth out, we place the implant, we immediately put the healing abutment on top of the implant, and this is the result we get 3 months later. And this is 2 years later. And I want to point out in these cases of immediately implants that if we get good primary stability of the implant and we utilize a properly shaped custom healing abutment, then we support the cervical profile of the tissue, we contain the graft in place, we protect the blood clot, and you can have an amazing maintenance of the soft tissue. I see that a lot of people, they feel more comfortable placing immediately implants and then put a stop healing abutment, and then they start putting a lot of sutures in order to close this gap. So basically what we do, we try to preserve the rich dimensions, but at the same time we start pulling this buccal tissue towards the lingual with sutures. It makes absolute no sense. So for me, any protocol that we can apply in order to maintain what Mother Nature gave us, this is the best we can do. Another example is in cases of PET protocols that they utilize socket sealed or root membrane. By utilizing an anatomical healing abutment that is modifiable, meaning that you can change the shape, we can ensure that we will have proper space between the healing abutment and the root shield. And this is very important because this way we can shape the tissue straightforward, and then the restorative dentist will just have to take a proper impression. I see again cases where the PET protocol has been applied, the stock healing abutment has been placed, and now they try to modify this tissue. But how can you modify this soft tissue? You don't know where the silt is. So by changing the shape of the gingival mask on your working model, you don't know if the final prosthesis or your temporary prosthesis will go and apply pressure on this silt and lead to mobility of the silt and complication. So again, as I said, PET protocols are great protocols where you can apply custom healing abutment, then duplicate this modified custom healing abutment and create a duplicate impression post, impress this, give it to the lab so that the lab knows what they can do and what they should not do. And this way you can minimize the chances of having internal root exposure or late complications through dislodgement. Now, it is great when we have cases that we can place the implant immediately and put a temporary abutment or a temporary prosthesis and maintain that. But what happens if we have a tooth that we need to take out, but the site does not allow us to be able to place immediately the implant or place immediately and furthermore load it with a healing abutment or a temporary prosthesis. So we usually, what we used to do is like regular socket graft techniques where we will take the tooth out, clean the socket, fill the hole with bone, and then put a collagen plaque on top of it and some sutures. Or for molar sites, we will make a small flap and tack PTFE membrane underneath, etc., etc. So what we did is we changed a little bit this protocol. We modified it based on getting an idea from Kostas Valavanis, and this idea was similar to things that the Tarno group and other people have done before with FPD over sockets. Basically, you go onto the socket with a guide, you identify the cervical profile of the tissue, and then we go to the mold of the system, put some composite, and we make something that we call a collagen composite plaque or a composite membrane. So this now has the dimensions and shape of the cervical profile of the soft tissue. So what we do is we just put it on top of the graft and connect it with the adjacent teeth. And this is 3 months later. You can see that we have very good maintenance of the bone in a case where we have soft, thin tissue biotype. And you can see that we also were able to maintain the cervical profile of the initial socket. Now, what we do is we will remove this immature epithelium that is present there, and we will just go ahead and place our implant. And after the implant now is placed in the proper depth, we are going to make a custom healing abutment of the same dimensions, and we will connect this onto the implant. So we maintain this cervical profile from the time of extraction to the time of placement. Now we maintain it to the time of restoration. And this is the emergence profile and cervical profile that we get at 3 months later. So now we make the duplicate impression post with the system. So we further support this through the impression states. We do the 1FPT technique, impression technique, and we transfer now this information to the lab. Now what the lab needs to do is design the prosthesis by basically following the supporting the existing soft tissue and utilizing biocompatible materials in the subgingival zone so that these materials can support the soft tissue and also accommodate the connective tissue adhesion and the junctional epithelium attachment. And like I said, we always aim for screw cemented restorations, not only to avoid cement escape, but also for retrievability. It's way easier when needed to be for this prosthesis to be retrieved. Finally, it is very important for all of us to understand that the prosthesis, when it comes to the lab, usually is dirty. It can have bacteria, fungus, etc. So it's very important to utilize proper protocols and clean it properly before we deliver it. And when the soft tissue has been conditioned properly, then it's very straightforward, the delivery process, without pain and discomfort for the patient. And this is where we started, and this is where we ended. This is a 6 months post-op of the same case. So basically, we were able to utilize this technique. Again, if somebody wants to take a look at the paper, just you can always email me. We have been utilizing this technique for molar sites or for anterior cases. Not for every case we can place the implant and immediately connect a healing abutment or a temporary prosthesis. However, with the CSP technique, in these cases, we can still maintain the soft tissue anatomy and make the process of implant placement way easier and more predictable. So basically, the cervical philosophy, it doesn't say anything new. It basically utilizes principles that we already have available in different fields of dentistry about optimization of implant position, bone, soft tissue, and prosthesis. A combination of all these factors in combination have to be optimized. So basically, the protocols that I showed you are very simple protocols that can be followed in order to optimize the implant transmucosal complex. And is based on research and literature that we have available, and Tomas and George and Rick have contributed to this literature, and we are happy to learn from all these people and trying to get this knowledge and put everything under one umbrella. So I'm closing up this presentation by the simple question: if we do all these things, are we going to be able to get ever 100% survival rate long term? Well, I can clearly give you an answer: no, there is no 100% survival or success rate in anything. However, if we look at what percentages we have in the real world, and if we look again what literature shows us that we can achieve just by providing proper prosthesis design, which in order to provide this proper prosthesis design, we need to properly shape the soft tissue. We can decrease by 75% the cases that we have with peri-implantitis. This is a huge benefit. This is something huge for the long run. But we will always have the host response. The host response will always be there. But at the end of the day, when a case comes to my office and the patient presents with bone loss and peri-implantitis, I want to know, is it really the host? Or is it something that is related to the surgical and restorative protocol? Because if I don't know that, I cannot answer with confidence to the patient that I can replace this implant and things are going to go better this time. So I'll give you this simple example. If you do a perfect root canal therapy and the tooth fails again, you know there's no much room for improvement in this treatment. So most likely you will recommend extraction of the tooth. The same way in implant dentistry, if we don't do things right from the beginning, then we know there is a lot of room of improvement, and vice versa. So it's a matter of confidence. Out of my journey over the last 5-6 years now that I'm working on cervical, one thing I came to understand that is the most important, and this is teamwork and team education. Unfortunately, I'm a specialist, I'm a periodontist, and I learned how to do surgery. And I felt that my job is done the minute that I connect a stock healing abutment on the implant. Now is the job of the dentist to take the impression. It's the job of the lab to make the prosthesis. This is not how it works, and this is not how we can achieve long-term stability. It's very important for all the members that they are involved in treatment to be educated on the same level, follow the same principles, and communicate in order to get ideal results for our patients. I'm located in Rhodes, Greece. It's also here night, like in Lithuania. And we always have beautiful summers. We are coronavirus free. So I hope to see a lot of people visit us this summer. And for whoever interested, they can combine that with education in our clinic. And with that being said, I try to be on time, and that's it. Thank you, Mark.
Fantastic. This is a beautiful overview, not only of the biology aspects, but also the surgical, and now finally the prosthetic phase. And as you know, when I saw the cervical system, for me, it made total sense to have this implemented in my practice. My wife's now using it. And for me, I see the failure of stock abutments to achieve what we want to do. And I think all dentists should be taking their time to implement this philosophy in their practice to enhance the healing and success rate of their implant treatment. So if you can close down the presentation now, we'll jump into a few questions.
I was trying to find the button.
There we go. So we'll start off with Dr. Miron, Rick, and I wanted to see his thoughts on future trends for surface treatment on implants? Do you see any developments in the future that could be applicable to decrease or help the success rate of implant dentistry?
Yeah, so that's actually a very good question. And we have done a little bit of research in that space. A couple of things. So of course, obviously, if you make the implants more hydrophilic, they're going to integrate better. I mean, that's been well characterized. And whether or not those implants are zirconia or titanium, both hydrophilic surfaces typically integrate better. And we've published that already. One of the things that was actually asked of us, and this was work that was done with Stroman. So we received a big ITI grant, and we were coating actually the implant surfaces with interleukin-4, which actually helps produce M2 macrophage polarization. So some of the strategy, and this is really related to people that have immune type disorders, these people will not integrate these implants as effectively. And so Stroman actually put some money in to try and develop an actual implant surface that had coated, instead of coating BMPs, for instance, on these implant surfaces, now people are trying to coat implant surfaces with immune type interleukins, etc. I'm just thinking on the top of my head, I'm not even allowed to know if I'm allowed to say this or not, because I can't remember if I signed a non-disclosure for that. But anyways, that's actually what we're working on in the labs right now. So.
Okay.
Yeah.
And this is a question for George. What's your thought on the kind of biomaterial to use in terms of these potential attempts at regeneration around those failed implants? Should we be using something that's not going to resorb, like a xenograft? Should we be trying to use something like an FDBA type of bone? Or what's your thought on the biomaterial of choice?
Yeah, well, that's a very relevant question, Mark. I think the problem is that, as we all know, around teeth, when you have gingivitis, the cellular turnover is extremely rapid. And that's because you have all these different sources of blood supply, and pretty much all the speakers touched upon it. And Ioannis, in the end, he made a great comment about how when you lose the PDL-derived blood supply, it's not only that, but it's that a lot of the medullary bone also nourishes the teeth through the PDL and whatnot. So by limiting that around implants, we just have much slower influx of cells. And that's a problem, because all the regenerative potential comes from two main things. One is the cellular populations, primarily the progenitor cellular populations, and then it's the right signaling, the right transcription factors to get these progenitors that can become a lot of different things and kind of force them to go towards the osteoblastic route. So just using a scaffolding biomaterial, kind of a little ladder for cells to go from the bony walls, that is where we can get them from in peri-implantitis, all the way to the implant surface, that's probably not enough. And at least we have in vitro data strongly suggesting that it's not enough. So when we first started off, we were using the strongest osteoinductive signal we could find, which was human recombinant BMP2. But that has two main drawbacks. One, it takes a lot of time to get the job done, and two, it's so expensive that it's almost less costly to go back and explant the implant and start all over again. And eventually, we transitioned to osteostimulated biomaterials. So we did all the in vitro work to figure out if they could just get us more bone cells at the time where we needed towards that surface, and they certainly could. So we've been focusing a lot on calcium phosphosilicate material use right now, which is osteostimulative. The problem with a non-resorbable form of graft, like a xenograft, for instance, an inorganic bovine bone mineral, it's going to stay there. And we've noted that we can not only build bone at a much lower pace, but osteoclastic activity, which is very well regulated and coupled with bone building, is also much slower because of the lack of these osteoclastic progenitor populations that primarily same ancestors and monocytes and macrophages. So to make a long story short, I'm confident that putting something there that is extremely challenging to resorb to begin with doesn't provide better volume support, but actually lowers the already slow regenerative potential and might cause problems down the road.
Before we jump into our next two presenters, I wanted Sanjana to let us know about her background that she has behind her.
This is actually from Professor Itzhak Binderman, and he's focused very much on dentogingival fibroblast, on gingiva, on immunology. He loves macrophages too, only good ones. And this is, I would like to ask you, Rick, a little bit about, you have shown Albrektsson work, and it really opened my horizons. And he says there is very little similarity between peri-implantitis and peri-implantitis. So little between arthroplasty and the native joint. And he always compares implants with arthroplasty. But then other sides, he also says, yes, but in amputates, when there is a prosthesis with connection, out and inside, there is 20% inflammation. It is not that similar, I think, arthroplasty and dental implants, because we do have this transgingival zone. And I would like you to elaborate a little bit on this collagen destruction, matrix metalloproteinase, and stuff like this.
Yeah, sure. I think the field is evolving, and the reason why I wanted to present his work is just to kind of give credit to somebody that's kind of thought outside the box over 10 years ago. And, I think I've had the opportunity to read Tomas Linkevicius' book, of course, on the zero bone loss concept, and you can really see how the field has evolved. The points that he makes are very interesting, and he never looked at it exactly. This is Albrektsson now. He never really looked at it directly as a tooth and a periodontal bacteria type disease. And the reality is, like I said, because we study so much in the lab, surface interaction with cells, and we're tracking things with cell biology models and with histology models where we can look at cells very early. So we'll take time points after 7 days and see how these implants are integrated. It's very interesting to see how immune cells are behaving around these implant surfaces. And that's the reason why in 2016, Dieter Bossart and I wrote that article called Osteomax Key Players Around Bone Biomaterials. And it's one of my most highly cited papers, for the simple reason that a lot of people are forgetting how important this immune system is. And so then when you fast forward and you're reading other people's work, and so now we can go to George's work and read about titanium particles. There's a very direct correlation with all the stuff that he showed. And I was so happy. I mean, I lecture a lot on PRF, and one of the things that I go to these holistic type conferences, and everybody's always saying, titanium is so bad, and people are allergic to titanium. And then he said, nobody's allergic to titanium. We've actually done that same work. So when he said that, I was like, God bless, please come to the conferences that I'm coming to, because sometimes I'll say that and I look like a freak, and I'm like, it's an inflammatory disease, exactly as he said. It's a chronic disease. So then, whether that be from titanium particles or from cement or wherever it is, it's very important to try and optimize the immune system. And so what controls the immune system and what is a powerful immunomodulator is vitamin D. And so that's where, when we were doing the same work with the allergy testing, we were noticing nobody's allergic to titanium. And in Bern, Switzerland, a lot of people don't know this, but a lot of the zirconia implants are actually developed in Switzerland. And our group in Bern, more than 10 years ago, we were doing work with Xeramax, with C Systems, all of these zirconia. And we actually thought that maybe when we were getting some of these implants that were failing, it was because of, allergies, because it was one of the first times we'd ever been placing zirconia or zirconia alloys. And nobody was ever allergic to any of these materials. It always had to do with inflammation or some kind of deficiency. And so I look to Albrektsson's work, and whenever he shows, for example, these hips that are just aseptic loosening and they're coming out, then you're sitting there and you're saying, well, why would that happen around? There's no bacteria there at all. So it's obviously something related to the immune system, and it's a foreign body reaction. And you need to ideally have some kind of optimization, or equilibrium is how he calls it. And that's where having, the vitamins, it's so simple, But when you put it all together and you're looking at every paper that's coming out in 2018, that big one that was done in Italy by Mangano, and showing the high correlations with vitamin D deficiency and implant failures, and you're saying, okay, well, you know, probably more clinicians should pay attention to how important the overall body and the overall immune system is to these things. And when you look at every one of these guys' research that they're doing, there's a correlation with every single presenter that was presenting today. One was titanium particle release. I'm sure a lot of concepts in the zero bone loss textbook, as well as the online program, really focus on, you know, excess cement or having biomaterials that are incorrectly placed. Essentially what it's doing is it's causing a little bit more of an inflammatory response. And, you know, that's the take on it today. Probably in 5 years, we'll understand more and the field will continue to advance. So I really enjoyed everybody's lecture today because, like I said, it's even eye-opening for me to see how clinically these clinicians are optimizing things and how all these things are interrelated. So,
yeah.
Well, if I may add something to what Rick just said, you know, it's amazing to me how on a higher level, what every one of the speakers today said absolutely converged. I mean, Rick's talking about vitamin D, and one of the main roles in vitamin D in the body is calcium regulation, and calcium regulation is, you know, directly linked to both bone building and bone resorbing activities. And if you think at it from an evolutionary perspective, you know, the body has a very specific way of responding to stimuli. And, you know, the main pathway for bone loss is the RANKL-OPG pathway. And, you know, very, very little can happen without that being activated. And the key players that are part in activating that are macrophages and other immune cells as well. So what changes here in each one's perspective is that the way to get there, the way to have the pro-inflammatory signaling that will eventually activate the RANKL-OPG pathway can be directly from bacteria, can be by titanium particles, can be by, you know, a lot of what Tomas said, just mechanical stress. And, you know, mechanical stress alone, without any bacteria present, can initiate an inflammatory response. Inflammatory responses are not only responses to bacteria, are responses to stress in general. So I think peri-implantitis is a multifactorial disease and way more challenging to treat than periodontitis because it has to do with a person-made biomaterial that's put in there. And that's just, to me, how many things have to go wrong to get peri-implantitis is impressive and still happens at a very, very high prevalence. So I'm just so thankful here today for the opportunity to listen to what I've listened to.
I would like to ask you, what does make you sure that the titanium debris is maybe not a product of inflammatory process? And so you found each time titanium, if there was peri-implantitis, or that titanium debris is a cause for peri-implantitis in these cases?
Yeah, absolutely. So the data we have right now are what we call correlative data, meaning that at, you know, one cross-section in time, we looked at people that either had healthy implants or implants with peri-implantitis, and we found near zero particles in those healthy ones, and just a massive amount, over 20 parts per million of titanium particles in the plaque of people with disease. So, you know, it's kind of the chicken or the egg thing here, where we don't know if the particles were there preceding disease, and if disease in itself, the inflammation itself, caused titanium particles to come in. But what seems to be the case, one way or the other, I mean, there's a lot of preclinical work that I didn't have time to show today, both from us and others, showing that a plaque biofilm alone around implants can eventually increase the rate of dissolution. Because if you think about it, the passivation layer is titanium dioxide. And as everything in nature, okay, even as zirconia, you know, Rick has worked extensively on that. So I think you'd agree with me, even zirconia will break down eventually. But, you know, one will do it, titanium dioxide in aerobic conditions will give us 0.0001 parts per billion a year, zirconia even less. So they're absolutely bioinert, and, you know, before I die, I won't have enough titanium particles from a healthy implant to cause a problem. So the safety of titanium implants overall is immaculate. It's amazing. But there must be a trigger that causes some implants to start breaking down. And this is what we need to identify. And this can be a lot of things, and it can be dentist related is what I fear, because we've shown that in the mouth where you have bacteria always present, omnipresent, if you accidentally nick an implant with an ultrasonic and you have bacteria present at the time and you have saliva that can potentially be acidic depending on your meals and everything, that potentially could initiate something. And you have to think about the fact that titanium particles, once there, they stay in the area and they can only accumulate, they can only increase. And that's a big problem. And as dentists, because most of us, I mean, honestly, we weren't taught implant dentistry in dental school. You know, I think I'm the most recent dental school graduate here, and I wasn't taught how to place a single implant or how to restore a single implant in my program. And there are intuitive things that we just haven't thought of applying around implants. For instance, one of the things that can accelerate corrosion of titanium implants is fluoride, high solutions of fluoride. But I've seen dentists, just because no one speaks about it. I mean, there's a ton of preclinical literature in the Journal of Dental Research or Monticello's journals that we don't read as clinicians that talks about fluoride being so electronegative, the most electronegative atom, right? And being able to break down titanium dioxides. And still, I've seen people prescribe Prevident and that being applied or brushed on implant surfaces. So really vigilance is what we can take out of here. And at least if there is any part of it that is dentist related, we have to eliminate that.
Mm-hmm. This is how Ioannis finished his lecture. Very nice. Like, I want to know, is it really the host or it was me? I would have another question for Tomas, please.
Yes.
And it is related to Spinato's paper. You know, Spinato paper, who compared the different collar abutment heights and patients with different gingiva vertical height. And he has found out in his research, I know this is a research that it's contradictory to Linda and your research and what we see in our daily praxis. But he has found out that the bone resorption was not depending on the vertical gingiva height, but on the collar height of the abutment. Do you know this study? Microphone.
Yes, I'm here. Yeah, so I know that paper. First of all, of course, we should start saying that every clinical study, we must look at materials and methods. So what was done there? So I looked at it, and they used the implant with polished neck, and they submerged it crestally. So actually, it was one of the confounding factors which was not isolated, in my opinion, in that study, because when you put polished neck below the bone, then tissue thickness becomes, you will lose bone because of the polished neck. Doesn't matter how thick tissues you are. For example, you can have thick tissues, let's say 4 millimeters, and I'm placing implant with polished neck and I'm submerging it. The bone will go away, yeah, because it doesn't matter that tissue thickness is high. So that's the idea. I mean, my whole take-home message and whole idea of the book on the course is, I ask clinicians, so which is the most important factor? And I later say that this is the wrong question. If you start asking which is the most important, it means that you don't understand the concept itself. All are important. This means, yeah, but they all are controllable. And this means that in studies, you must isolate other factors in order to determine which factor which factor you are researching. So that would be a comment. But generally, of course, you know, this is every study might have some different, let's say, way of doing it, and I think there is no any, how to say, question in our profession which has 100 unanimous answer. So I completely accept this different outcome, and I'm glad that people are doing it. I mean, that this brings again the more focus on this vertical part of our tissues, which I think should be always evaluated before implantation.
Absolutely. Agree.
Another question for Thomas, and this is not a research-related question, but more so for clinicians that are just starting off on their implant journey and are watching this. And you have sales reps or companies coming by and promoting different products to them. What would you look for in an implant design if it was something that you had a choice in today? Would you be placing a certain connection, a certain implant with certain features that you would be looking for? What are your thoughts on that?
Well, again, it depends also, of course, on implant design, which we're choosing to work with. Idea is that you can have, I mean, as I was saying in the lecture, there is no ideal design of the implant, because different implants must be used differently. You cannot compare, let's say, just from design point of view, tissue level and, let's say, more tapered implant. Okay, so you have different philosophies. And how can you say, I mean, look, the connection stability is better here, it means that it's better implant? No, I mean, they are just need to be placed differently, and then you can see the features which are implemented in that implant. But if we would reduce, let's say, to give more clarity to answer, let's say we're talking about bone level implant. Yeah, the implant which I'm placing at the level of the bone or below the bone. So this implant should have three things. Should have a stable conical connection, and stable means no more than 15 degrees of angulation, should have platform switching, and should not have any polished part on it. Then if this implant has these requirements, I mean, you just need to look and read how it's made, then you can place it at the level of the bone or below the bone, again, depending on your clinical situation.
Okay, so why don't we take one last question and we'll wrap it up for today. This is a question for Ioannis, and as you know, you mentioned even in your presentation, the need for these kinds of custom healing abutments, and I think in the same manner, comes more into play in posterior implants. And I see people thinking that in posterior implant zones, they can get away with using a stock abutment, where more so the need for a customized abutment plays into the posterior zone more so. So what's your thought on that? And you know, are stock abutments sufficient for molar zones, or are you customizing everything, or what's your thought?
Well, for anterior cases, basically you can go with temporarization, because you can serve two things at the same time whenever this is possible. But for posterior cases, I think that it's way more important, because the diameter, the dimensions of the cervical profile of the prosthesis become wider. So it's very important to condition this tissue and not create a rich lap effect. Now, anatomical healing abutments is not the only way. You can do cervical contouring technique, or you can do dynamic compression technique. The reason that I'm utilizing the anatomical healing abutments is because it's easier. I do not need to do more appointments. I do not need to outsource things to the lab and increase the cost of treatment. For instance, I will give you a small example. the cervical contouring concept by Nitzan. If the surgeon and the restorative dentist is not the same person, let's say I'm the surgeon and I go place the implant, then I connect a stock healing abutment, a narrow stock healing abutment to get maximum tissue. Okay, now this fits on the implant. I send this now to you, Mark, and you take an impression, send it to the lab, and you ask the lab to shape the gingival mask on the model in order to give a proper shape of tissue. Now you do that, you get the final prosthesis, the lab sends this final prosthesis to you, and now you try to stick this huge prosthesis into this small hole, transmucosal tunnel there. So what happens is, first of all, this is extremely painful. You need to do local anesthesia. The second thing is, I have done this, anything I saw in my lecture, I have tried it. So we have done this technique. And before I knew better that I need to cover the patient with steroids and anti-inflammatories, I had 2 cases where the patient became very swollen. The biggest problem is that if I don't understand as a surgeon the prosthesis design, I do not adjust the topography of the bone, then this anatomical design of prosthesis will not fit on the implant because the bone will interfere with this. And this is especially true for submerged cases. Now, when you go to dynamic compression technique, is basically a modification of the cervical contouring technique, where you do things in stages so that you can make the whole process more comfortable and easier. The problem is that you start now doing multiple connections, disconnections on the implant, and you need to increase the time and cost of treatment because you need to outsource this to the lab, expand the tissue, again 2 weeks later, do the same thing. I just don't understand why you need to go through all this when you can create everything from the time of surgery or maintain everything from the time of extraction, either with place the implant and connect the healing abutment, anatomical healing abutment, or the CSP technique, whatever you feel comfortable with.
No, I totally agree with you. And I think more and more clinicians should start to implement this in their practice. And unfortunately, not a large percentage of people are doing it. I think it's a shame. It's either due to, either being lazy to do it or looking at the cost factors, when in the long term, something like this would for sure benefit. So
well, if they do what they do and they don't have problems, I recommend they shouldn't change anything. I changed things in my practice because I had problems. That's why I try to do things better.
No, yeah, I mean, at least in my office, like my inserts are much quicker also by customizing the tissue. There's often no local involved in the inserts and they're much quicker. I think, like you mentioned, you can get a lot of pain or discomfort. Maybe in the posterior zone, you can get away with it, but in the interior zone, you could end up with recession or issues down the road from overcompression.
Yeah. Well, the problem, Mark, is I mentioned in my lecture. The problem is I place the implant as a surgeon. The case goes to the dentist. It gets restored. Then the patient at some point goes back to the dentist. He says, "I'm hurting my implant." They put some pressure on the gums. They see some pus coming out, and they say, "Go back to the surgeon." And this is what is going on. And people that they work as teams and they do the whole process themselves in the clinic, or it's a team of surgeons and restorative dentists in the same, under the same roof, they don't see that. But reality is not this. The reality is that we have like surgeons that place the implants, dentists that they restore the implants, and there is no communication between each other. And this is what is going on, and this is why we have a lot of a high increase in the prevalence of peri-implantitis. This is my opinion.
No, for sure. Okay, so thanks everyone for taking your Saturday to join us today. It was a wonderful presentation by everyone involved, from biology to surgical to prosthetic. It's been a wonderful Saturday, and I hope whether you're starting your day or ending your day, to enjoy it.
Perfect. Thanks again for having us.
Thank you, Mark. Take care. Take care, everybody.
Take care. Take care.